Good morning, one and all. Today I'm going to be speaking on my free paper on muscle biopsy. Do you change? We have nil financial disclosure. The purpose of our study was to evaluate the role of muscle biopsy in the diagnosis and management of patients presenting with isolated extraocular muscle lesions. So it was a retrospective analysis conducted on 23 eyes of 18 patients who underwent muscle biopsy in a period of 12 years. We ruled out vascular and infectious etiologies, and we studied the demographics, radiological, histopathological details, surgical details, and the clinico-radiological outcomes of the patient. We performed the standard technique of an open muscle biopsy where we did a conjunctival peritomy, incised the Tenon's fascia to expose the muscle of interest, and then the biopsy was taken from the orbital layer of the muscle, ensuring to stay parallel to the long axis of the muscle and avoiding damage to the motor nerves. We used tooth forceps, gripping the specimen only once, avoiding crush artifacts. So the mean age of the patients in our study was around 42 years. There was a slight male predilection, and the most common chief complaint they presented was proptosis. We had around 13 patients who presented with unilateral lesions and 5 patients presented with bilateral lesions. The most common muscle that was involved on imaging in our study was the lateral rectus muscle, and the indications for biopsy were those patients who didn't improve with empirical treatment and lesions that were clinico-radiologically inconclusive. The most commonly biopsied muscles were the lateral rectus and the inferior recti muscle. This is a tabular column showing the suspected diagnosis and the diagnosis after muscle biopsy. So we had 7 cases of IOID, 2 cases of dermoids, 2 lymphoproliferative cases, 2 granulomatous inflammations, 1 leiomyoma, and amyloid deposits. So in 9 patients, the diagnosis changed after biopsy, and in 7 patients, it was confirmed. In 2 patients, the biopsy was inconclusive. So there was an overall clinico-radiological improvement of 83.1%, which was statistically significant. I'd like to discuss a few case scenarios. This is a patient who was a 60-year-old male who presented with a painful diminution of vision, sudden onset, since 1 month, and he was diagnosed elsewhere to have orbital cellulitis, and he was treated with oral antibiotics but did not improve. Imaging showed a well-defined enhancing lesion in the right lateral rectus and a ring enhancing lesion in the left inferior rectus. Biopsy and then immunohistochemistry proved this lesion to be a neuroendocrine tumor. A PET done showed that it was from the distal jejunal loop. This patient received systemic chemotherapy but succumbed to systemic disease in 2 years. This is another case of a 47-year-old male who presented with a progressive inward deviation of the right eye and diplopia. He was treated elsewhere as an IOID and given oral steroids but did not respond. Imaging showed a well-defined mass in the right lateral rectus, and on table, the mass seemed to be infiltrated with yellowish deposits. So this led us to suspect a neoplasm or a metabolic disorder. Histopathology then confirmed it to be amyloid deposits. This is another case of a 20-year-old female who was a case of recurrent IOID, not responding to oral steroids. On imaging, we saw a tendon involving mass, and we suspected either an IOID or neoplastic lesion or IgG4 disease, and histopathology proved it to be IOID. She did well with a course of mycophenolate and intralesional steroids. So extraocular muscle enlargement can be either inflammatory, vascular, metabolic, or neoplastic in origin. And depending on the muscle involved, we have different approaches. Among the different biopsy techniques that have been described, the open technique is the one that's most commonly used and the one we used in our study. So this is an algorithm that shows us on how to approach a patient who comes with muscle enlargement. So if the patient has imaging that's consistent with TED, but the history and clinical findings are not, or the imaging is atypical of TED, but the patient doesn't show any response to a corticosteroid trial, or the screening for metastatic disease is negative in the case of a known malignancy, one can proceed with a muscle biopsy. So just like in other studies, in our study also, the IOID was the most common cause of EOM enlargement, and there were few complications reported in other studies like diplopia, adhesion, ptosis, and infections following biopsy. In our study, 2 patients were complicated by symblepharon and rupture of dermite cyst while performing the biopsy. So we had a few masqueraders in our study, like there was a case of sarcoid granuloma, which is thought to be a thyroid eye disease, and a neuroendocrine tumor, which I just described, which presented as a hot orbit. And similar reports have been described previously in literature. We also had 2 cases of lymphoproliferative lesions, which were thought to be TED and myositis earlier. A paper by Bodo et al. Has also reported similar cases. The limitations in our study was that a single surgeon did not perform all the cases, and our sample size was too small to bring out the association between the patterns of the muscle involvement and the disease. The use of steroids before the biopsy could have been a confounding factor, and the retrospective nature of the study could have introduced an investigator bias. However, muscle biopsy does play a critical role in lesions that are clinico-radiologically inconclusive and those that don't show response to treatment. It is a simple, easy to perform method which has low morbidity, and it significantly improves the treatment outcome. Thank you. Yes, sir. We didn't follow any fixed duration before stopping, but we stopped the steroids because that would alter the histology. 2 weeks to a month, yeah, was like. Yeah.
The other thing is that you mentioned about a case of dermoid. Was it not diagnosed on radiology? The case of dermoid was there.
Yes, sir, it was. It was suspected to be a dermoid, but it was only involving the muscle. So this was a case which we almost thought it was a dermoid. There was no real confusion as such that it could be anything else. It looked like a dermoid. But then we had to do a muscle biopsy because it was involving specifically the muscle itself. It was a confusion between a dermoid or a lipoma, but dermoid was the one that was more, we were thinking in terms of.
That was incisional biopsy, not axial.
On table, it looked like a dermoid, so there was an attempt was made to excise the mass. Yeah, it would be an incision biopsy because obviously the muscle would not be excised as a whole.
So the take-home message you wanted to give is that initially we should go for some medicinal treatment, and then if it doesn't works out, do a muscle biopsy.
Like we should be a little, we should have an index of suspicion in cases where we cannot just blindly treat all cases thinking it's an IOID with steroids, because a lot of some atypical presentations like we always think of TED and IOID, so we should just keep in mind that if it's just like a painless presentation like involving a unilateral muscles which are not commonly involved in TED or IOID, maybe we should think of other diagnosis. So, but most of the cases we got were treated with steroids elsewhere and then they had come to us. So it's just something that we could do which could hasten the treatment.
Did you find cases of muscle weakness post-op?
We didn't have, but there were reports have been there, but we didn't have any such diplopia, post-op diplopia or anything.
Not a single case?
We didn't have.
Okay, thank you, Prithvi.
Thank you.
Is next speaker Dr. Shobha Jawar present?
Good afternoon, everyone. So at the outset, I thank the association, Maharashtra Association, as well as the All India Society for giving me this opportunity to present how we tamed the ferocious mucormycosis wave. So second wave of the dreadful COVID-19 wave, March 2021, we started getting patients of orbital cellulitis in COVID-affected patients. And by second week of May, we had begun to see crops of these patients. And as I intimated my dean, she took cognizance and gave me the gigantic responsibility of being nodal officer, mucormycosis. And from there on started the massive job. So ROCM, as you know, is a dreadful, life-threatening disease seen in immunocompromised post-COVID patients. The disease starts in the nose, engulfs the orbit, and then reaches the brain. So the plan of action that we followed was we organized and attended various webinars wherein discussions were held with national oculoplasty surgeons like Dr. Santosh Honawar, Dr. Ramesh Murthy, and likewise also discussions with departments of ENT, medicine, and micro. A committee was formed for the institution, and SOP was formulated. A separate ward for mucormycosis was designated. Drugs were procured and management was planned. So life-saving measures that we took, prevention was employed by increasing the awareness about the science in post-COVID patients. Early diagnosis and high clinical suspicion was the goal, and early intervention was done to save life, to save eyeball, and to save the vision. So this is how the patients presented with tense periorbital edema, proptosis, chemosis, extraocular movements fixed, and some eschar around the eye. So the same patient MRI showed pan sinusitis here, as well as the orbit was involved, orbital apex was involved, and extension into the cavernous sinus. So treatment was, of course, a team approach wherein the medicine people went ahead with the glycemic control and reversal of immune status. Systemic antifungals like IV liposomal amphotericin B was started, and also syrup posaconazole. Surgical treatment plan was functional endoscopic sinus surgery, where radical debridement of multiple sinuses was done, and debridement of medial periorbita, where required irrigation with local antifungals, tram injections, and exenteration. So this was a schematic diagram that I chalked out for my residents to follow, wherein you can see in the first two, where there was just a periorbital edema and no other signs, we went in for FES surgery. While as where a proptosis was there, chemosis was there, extraocular movements were restricted, but the vision was not affected. There we went in with tram injections, and wherever there was chemosis, proptosis, eschar, and where the vision was no PL, we went in for exenterations. So local amphotericin B was effective because it was a vaso-occlusive disease and caused necrosis, inviting the fungus, and here in this dead devitalized tissue, the systemic antifungals won't reach. So tram was effective as an adjunct therapeutic option for this, where in earlier orbital presentation and where vision was present, so there we used tram, but it could not replace exenteration because this was a life-saving procedure. So liposomal amphotericin B injection, in the dose of 3.5 milligram per ml was given OD. This was how the injection was given, and so in such cases where a lot of findings were not there, we went in with FES surgery, and here where some restriction of lateral movement was there, then tram was given with a good result. Here again with extraocular muscle movements were there, vision was there, so we went in with tram injections, and here extraocular movements were all restricted, and you could see the post tram picture which gave a good result. Here again the post tram picture you can see, and for this young fellow also, where prominent fat stranding were seen on MRI, we gave in tram injections. So tram was an advantageous, simple bedside procedure. It minimized the fungal load and reduced the progression of orbital infection, and visual acuity was restored. So this, in conjunction with IV antifungals and FES, salvaged the globe and vision of the patient. So this was how FES was done, inferior orbital debridement in certain cases. Exenteration was done to prevent further spread into the intracranial extension and save the life of the patient. It was done in no PL eyes, and where orbital apex and diffuse involvement was there and cavernous sinus was involved. So in such cases where scar was there and proptosis, we did with lid sparing exenteration. So this was how exenteration was done, and in few cases. So this was the data, the monthly data right from June to February 222, where you can see 353 cases were treated, wherein we did exenteration in only 9 cases, and 53 cases we gave tram. So this was the surgical data, where FES and tram was given in 53 and exenterations done only in 9 cases. So these were the results. The treatment was challenging. So lives saved 83.29%, eyes saved 96%, and exenteration only in 2.54, that is 9 cases. So in conclusion, I should say early intervention, proper charting of management, multidisciplinary approach, tram, and also IV amphotericin B, all these helped us tide over the ferocious mucormycosis wave successfully. These are the references. Thank you so much.
Can I ask a question?
Yes.
See, what was the dose of tram? Like, did you give it once daily or twice daily?
Once daily, and alternate day 3 injections. That was what we followed.
3 days a week?
Pardon?
Alternate days. you said.
Alternate day, yeah.
So 3 days a week.
Yeah, maybe 3 days a week, yes. So if the patient was responding, only three injections would suffice, or else we would increase it to 5 injections.
And after reconstituting, would you finish it off or would you preserve it in the fridge?
We
The
would finish
injection.
it off, the injection, yeah.
Finish it off.
Yes.
Did you use the same regimen for all the patients?
Yes, yes, most of the patients.
Given and the patient is not responding. So, additional were added or whichever
No, they were given IV liposomal amphotericin B with that. If the disease progressed, yeah, then we went ahead with exenteration. So depending upon the radiological findings.
your cutoff was like 3 injections per patient if they are not responding.
Till 5 injections we were giving, yeah. If not responding, or if it was not halted and it was progressing, then we had to go for further. So in a few cases we did inferior orbital debridement only, or FES with medial periorbita
Did you encounter any
debridement.
condition when it was for TRAP or
Yeah, in a single patient we encountered a post injection inflammation.
any retroviral happened?
No, ma'am, no.
And was the cause of death analyzed to be mucormycosis? in
Yeah,
all
death,
cases,
cause
or-
of death. Maximum patients' death here occurred before we could understand what is happening. So in the first 10 days of May, like we were not even able to realize what is happening. They were coming with severe proptosis and eschar, a big eschar. In those cases, then we could not save those cases, and they used to die. They were patients who were positive and already in ICU, so still positive. So before we could do anything for them, they would die.
No, my question is those who died,
Yes.
would we analyze that that cause of death is mucormycosis or something else?
Another what we thought of was this was not studied and still not studied, was maybe an involvement of pulmonary mucormycosis also happening into these patients, and maybe that was the reason why they died.
Because a lot of cardiomyopathies were the cause of.
Yes,
death.
cardiomyopathy, another cause, yeah,
Okay.
because this is a vaso-occlusive disease finally. But this, with the eschar and prominent mucormycosis, of course, that was the cause.
What was the average number of injections in your study?
Yeah, 53 cases, average 3 was effective, yeah. So within a week we could get good results. Mean was 3, sir, 3 injections, yes. In very few cases we had to go for 5.
Okay, ma'am. Thank you for
Thank
your
you, sir.
presentation.
Thank you very much.
PMMA as an orbital implant in enucleation and evisceration. So following evisceration and enucleation, an orbital implant is used to replace lost orbital volume, maintain the structure of the orbit, and impart motility to the underlying ocular prosthesis for optimal result. The PMMA is a non-integrated, non-porous solid implant which is cost-effective alternative to various porous orbital implants mostly used in the Western countries. Limited studies have used sclera as a wrapping material for PMMA implant in enucleation with varied outcomes. So, no Indian study has reviewed the outcomes of PMMA orbital implant, both evisceration and enucleation, which had the donor sclera wrap technique. And there is a paucity of literature on the outcomes of PMMA implant with donor sclera wrap technique in enucleation with regards to the motility and the complications. So, our aim was to study the clinical outcomes of primary PMMA orbital implant patient following evisceration and enucleation at a tertiary eye care center in central India. The primary objective was to evaluate the implant movement, implant retention and implant migration, if any, after enucleation evisceration with primary orbital PMMA implantation. And secondary objective was to study the implant related complication like implant exposure, implant extrusion, conjunctival dehiscence and superior sulcus deformity in patients after enucleation and evisceration. So study area was the Oculoplastic Service, MGMI Institute, Raipur, Chhattisgarh. It was a prospective interventional case series of 12 months duration, and 45 eyes of 45 patients were included. Inclusion criteria were the painful blind eye, infective or non-infective, And intraocular malignancies like retinoblastoma, uveal melanoma is included. Severe ocular trauma with non-cell visible globe, phthisis bulbi, atrophic bulbi, and panophthalmitis. Exclusion were post-traumatic severely contracted socket, post-irradiation contracted sockets, and patient with retinoblastoma who were due to EVRT or congenital anophthalmia with contracted socket. So methodology included the demography and detailed history of the patient, comprehensive examination, specific examination which was required for the particular case, relevant investigations, and the type of surgery, surgical technique, follow-ups, and rehabilitation with prosthesis was noted. So the implant size was according to the axial length of the normal eye, and sclera used as a repairing material there was 1.5 millimeters. Formula used was the implant diameter axial length minus 5.5 millimeter. Final decision on the size of the orbital implant to be used was based on the clinical and intraoperative findings of the patient's orbital and ocular anatomy and the space. So follow-up came first post-operative day, first 4-6 weeks post-operatively, and the 48 weeks. Custom ocular prosthesis were fitted on the 6th week post-op follow-up. On the follow-up period for custom ocular prosthesis, parameters like implant motility, orbital volume displacement, the minor complication, major complication were assessed, documented, and analyzed. So descriptive statistics will be used for this study. So these are the surgical procedure which were done. This is the evaluation with PMMA implant placed in the scleral pocket, and it was sutured with vehicle suture and the standard procedure. Then the enucleation was done. This is important. So here in the enucleation, the wrapping material used was the sclera along with the PMMA implant wrapped in it, and 4 recti muscle was sutured to the 4 quadrants, and then it was closed. So following the post-operative period, we see the implant motility here with the scleral wrapped orbital implant as compared to the normal eye, and following the addition of the prosthesis gives very good cosmesis along with the motility. So mean age of presentation was 41 years, mean axial length was around 22.43, mean size of the PMMA orbital implant was around 16 millimeter, horizontal excursion was around 7 millimeter, vertical excursion was around 8.9 millimeter, and the motility index was around 4 millimeter. So most common diagnosis was the perforated corneal ulcer followed by the staphyloma and the phthisis bulbi. The presentation is mostly acquired condition were more compared to the congenital, and surgery performed were mostly the eviscerations 2/3 and enucleation 1/3. The orbital volume replacement was good in 78% of the cases, and orbital implant was written in 98% of cases. Major complications were around only 7%, implant extrusion and exposure, and minor complication was around conjunctival dehiscence, which was around 7%. So these are the literature search which I have done. Orbital implant size, average size was around 16 mm in our study, which is equivalent. And orbital implant outcome was better in our cases, like exposure was 2 and 5%, and implant retention was also better, 98%, and the excursion was also comparable. So the PMMA orbital implant following evisceration and enucleation with the scleral wrap is a good cost-effective option which provide adequate volume replacement along with a good anatomical and functional outcome in relation to the implant and prosthesis movement with minimal complications. Thank you. These are my references. Yes, in the enucleated eye, we used a scleral wrap. So what it adds on is that one is the availability. We have the availability of donor sclera, and advantage of that is that the extrusion and the exposure is very less in this. And in my technique, what I have done is once the donor sclera is taken, I put the implant inside, and then I reverse it out. Like the open end will be towards the inside of the tenon space, and the external part which you see in the center, I take the optic nerve stump as the central point. So that is a advantage for me to attaching the muscles. This will be the central point, and 4 muscles are attached in 4 quadrants. So in that way, I have excluded that there will be no exposure or extrusion of the implants, and thereby even the motility is good because I am attaching to the sclera at the point of insertion, which is normally in the sclera. So there are two parts of it. One is the complication part and second is the motility part. Yes. Yes, sir. Yes, yes. We have. Numbers were not same, but we have compared, and it was comparable. That was one of the significant finding what I've seen. I attach it directly on the sclera. Donor sclera. Slight make a fibrosis so that it attaches. But from my experience, I have got very good results. And the motility part is very good. And patients are very satisfied with that. Judges.
How you have calculated the size of the implant?
Yes.
The formula which we use is the axial length -2.
Yes.
But in your presentation you mentioned axial length
5.5. Yeah. Because sclera is a component. Sclera is around 1.5 and the prosthesis is taken around 4 millimeter, the thickness. So I deducted from that. So it's coming to 5.5. So,
Because if you follow this formula, then there is a
and moreover,
possibility we might put a implant of
smaller size. But previously we had like putting a very big implant size. But over the period of time, we saw that there are a lot of complications were associated with it. So nowadays we are coming to an optimal size, which can have a better motility and also cosmesis with long-term no complication effects. So I believe in my patients, I get a very good volume replacement along with a good motility and cosmesis. Evisceration. Mostly it was like if it's a very big anterior staphyloма, if it's a thysis bulbi or with intraocular tumor suspect. Then those cases I had taken for enucleation. So most of the patients were evisceration because nowadays it is just shifting terms towards the evisceration if the globe is intact, not suspecting an intraocular malignancy. Yes. Yes.
So you are wrapping it in classical eye also, where even otherwise the conjunctiva is not optimal. So will it not be chances of
No. The reason is that the wrapping technique which I am using. So.
But you need to have something to support your wrap material.
Yes.
So whatever you use, if the pressure on conjunctiva is more and you are not having posterior demon to cover it up, it will definitely expose.
There is some modification like the size of the implant and then the size of the or thickness of the prosthesis. So these two we balance it and accordingly the cosmesis is slightly better as compared.
I just wanted to say that it's nice that you can collect the whole eyeball because usually people don't agree to it.
Yes. Sclera, even if it is used for scleral grafts and other patch grafts, so sclera is available, of course. Like
Your eye bank is supplying or at your place who's collecting the eye?
no,
Nowadays we only get the corneal button.
corneal buttons.
There are a limited eye bank who gives you sclera.
Yes, they are supplying actually. What we are doing is we are getting the corneal button only. But when we get the supply, it's from the sclera. I get from Arvind basically.
Right, sir. Thank you. So we
Thank you
have
very much.
3 speakers who were absent during the slot. I'd like to recall the names if they are present now.
Rahman, right. Dr. Sindhuja Murgesh, okay. Dr. Khare Mukesh,
Good afternoon. So I'll be talking about the management and outcome of traumatic NLDO in a tertiary eye care center. So the secondary NLDO is most challenging lacrimal disorder, especially in the view of its diagnosis and management, and trauma is one of the most common cause. So it can either be an iatrogenic cause or a non-iatrogenic cause. So iatrogenic, as we see most commonly after any sinus surgery, such as any FES or septoplasty, and non-iatrogenic cause, the most common will be your midfacial fractures and your naso-orbito-ethmoidal fracture. So why is the traumatic NLD very difficult coming to diagnosis is because of its soft tissue edema, the scarring and bony displacement can give certain pitfalls and even affect the surgical prognosis. So usually a reassessment should be done 1 to 3 months after the initial trauma. So managing an NLDO is very intimidating because the nasal, the bony anatomy is altered following trauma due to the presence of even any post-operative scarring and fibrosis. So proper clinical assessment and pre-operative lacrimal imaging is very important. So our study was a retrospective study done in 13 patients from September 2017 to 2022. So it included all patients with NLDO with post-traumatic NLDO with epiphora, and exclusion criteria was primary NLDO, functional NLD, canalicular injury or obstruction, eyelid abnormalities, other causes of secondary NLDO, and patients who lost to follow-up. So detailed history was taken, lacrimal system evaluation was done, syringing, tear film height and probing. CT DCG was done in all the patients, and ENT opinion was taken preoperatively to rule out any nasal pathology. So the interval between the trauma and the lacrimal sac was around 2 months to 3 years. And in our study, all the patients underwent surgery under general anesthesia. So the follow-up we did at the first day, 2 weeks, 1 month, 3 months, and 6 months, and every year after that. The patency of the new drainage ostium and complete cessation of epiphora was considered as an absolute success criteria. Intra-op and post-op complications were noted. At each visit, patients were asked about the symptoms of watering, the incision site was examined, and syringing was done. So an epiphora with patent irrigation was suggestive as functional failure, and epiphora without a patent irrigation was noted as an anatomic failure. So out of the 30 patients, 20 were male and 10 were female. And most common, the nature of injury was among the road traffic accidents, which we saw in 77%. And only one patient we took for the facial-maxillary surgery. So other common causes of traumatic NLDO commonly we saw was the NOE fractures in 67 patients and the maxillofacial fractures in 27 patients. So previous surgery in our study, most of the patients had no previous surgeries. So other associated features, traumatic telecanthus was most commonly seen in most of 60% of the patients, suggesting that this is a very important sign in traumatic NLDO. So as you can see over here, the patient has left eye traumatic telecanthus with an NLDO, and the down one also patient has a traumatic telecanthus with a depressed nasal bridge and a right-sided NLDO. So this was with traumatic NLDO with phthisis bulbi and traumatic NLDO with the gross anaphthalmus. So coming to the symptoms, majority of the patients had watering, and 40% had watering with discharge, and only 3 patients had watering with the sac swelling. So in CT DCG, common what finding we saw in 20 patients was the fracture at the nasolacrimal junction, commonly involving the nasomaxillary suture and the frontal process of the maxilla. So as you can see in this patient, the left eye, traumatic telecanthus with left eye NLDO. So the contrast fills in the level of only the sac but not at the NLDO. So similar in this patient, this is a patient of post ORF and a Leafourth fracture. So this also shows contrast filling in the canaliculus and the sac but not at the NLD. So coming to our results, 27 patients underwent external DCR with a large rhinostomy, and out of which 18 with silicone tube and 9 patients with no intubation. And 3 patients underwent DCT because of severe scarring or fibrosis and inadequate ostium which we couldn't make intraoperatively, and because surgery difficulty due to the plates and the screws. So intraoperative hurdles which we saw were bleeding, tissue dissection difficulty due to fibrosis, sac fibrosis and thinning, altered bony anatomy due to the plates and the screws. So what this is a few of the cases of pre and post-op. So below patient, we had put a silicone tube intubation. So in coming to functional and anatomical success, we had in 25 patients out of the 27 patients who underwent DCR, and 1 patient had a functional failure, and 1 patient had a recurrent NLDO due to anatomical failure at one year follow-up and required a repeat DCR. And out of the 18 patients with silicone tube intubation, 1 patient had tube extrusion. Coming to the discussion, so it can either be a temporary dysfunction or even cause a permanent dysfunction. So iatrogenic NLD, it's because of the anatomic close proximity of the lacrymal bone with the uncinate process. So NOE, what are the findings which we see? It will be medial and inferior orbital wall injury, depressed midface bony architecture, mobile midface, telecanthus, anaphthalamus, nasolacrimal duct injury. So why this NOE causes NLDO is because the duct traverses through the lateral wall of the nose to enter the nasal cavity. So DCG, what is the importance is, it causes, it can even, the fractures can be seen, exact localization of the lacrimal sac can be noted, even the previous screws and plates which are there can also be made out. So coming to the other discussion, ORIF, if the fracture is done, it will minimize the incidence of post-operative epiphora, and external DCR has a very good success, I don't more than 90%. So why endoscopic, endonasal and laser DCR is not advisable is because of the loss of bony anatomical landmark after trauma and the subsequent surgery. So even many studies have shown the good success rate. So the limitations in our study was it's a retrospective study, a very small sample size. It's not a case control study, and we couldn't contribute to the iatrogenic part of the NLDO. Yeah. Sorry. That's it. Yeah, that's it. That's it.
Two questions.
Yes, sir.
Clarification on your slide. So in your slide, you had mentioned that during surgery you made a large rhinostomy.
Yeah.
What do you mean by large rhinostomy?
At least minimum of 10 into 10 millimeters.
Okay. So that is, you have made large in these cases. Other cases you will prefer a smaller rhinostomy.
No, I mean in traumatic at least more than that. In a standard DCR we have to do that at 10 to 10, but in this traumatic at least more than that.
Okay, so it becomes a very subjective term, a large rhinostomy. We are not clarified. So that's one. Secondly, in that same slide, you had mentioned 3 patients were taken for DCT.
Yeah.
Because of inadequate osteotomy and screws and
Fibrosis.
So
and
those patients, your initial plan was DCR, but you failed to do a DCR.
do a DC. On intraoperatively we couldn't do a DCR because of all the fibrosis and the inadequacy of the osteum. We couldn't do a DCR, so it went for a DCT.
So in case you are having screws and plates and you are doing CT, DCG for all cases and other investigation, you would know that beforehand, no?
Yeah, but
Why would it be an intraoperative challenge to take up that patient?
intraoperatively
Or we
because
could plan for removal of screws and plates and then take up for surgery in the same sitting.
yes, sir.
You may have information, but on that slide it comes across as a little inadequate. That's it.
What problem faced during the osteotomy, particularly in the traumatic cases?
Sometimes during the osteotomy, the bone can be very friable, so even the sac can also get damaged while doing the osteotomy, especially in a traumatic NLDO, if there is fracture along the lacrimal bone.
Okay, you said that syringing done and it was patent. So further, did you do any investigation? Or you just termed it as a functional obstruction or epiphora?
Yeah, we did a Jones dye test as well, sir, but in that also it was, retention was noted.
Okay, there is another simple test that is FDDT.
FDT, yeah.
So that would have been performed and that would have been also recorded in this. So you would have known at least how much is the functional epiphora part. And how is the role of DCG here?
DCG you can only see the lacrimal this thing, but with the traumatic NLDO for fractures and any plates and screws, that we'll not be able to pick it out just in a DCG.
Does that have any role in the
yes, it
treatment
does.
prognosis?
Yes, it does, sir.
So
Because if fractures are there and then intraoperatively you can have certain difficulty, or if you want to do anything else for that, so it's better always to do a CT DCG than just a DCG.
because that will be an additional cost for the patient also.
Yeah, of course.
Okay, if you have a cost benefit analysis. Thank you.
Thank you.
So next, I'd invite Dr. Ravi Ranjan to present his paper on repeat DCR.
Topic for today is my topic for today is DCR, a small flap saving technique. No financial relationship to declare. As published in various journals, success rate of external DCR is 85 to 98%, and in spite of excellent success rate, there are large number of cases with failure, typically due to poor surgical technique and intranasal adhesions, fall of mucosal flap, etc., etc. And the impact on surgeon, who is the second victim, is significant, and the effect may be psychological, physical, emotional, or behavioral. And personal communication with many ophthalmology reveal that the failure of the procedure and tedious flap making in DCR are the main cause of reluctance from this surgery, and as a result, the DCR is ignored by many eye surgeons, particularly in peripheral areas, and lacrimal surgery is increasingly by being undertaken by ENT surgeons, and that's why we are losing our domain by ignoring this. And that's to overcome that problem, we conceptualize this method to repeat DCR surgery, which is easy to perform with successful results and short learning curve. And changes we made were use of Aruga's bone trephine, and approximately 1 to 2 mm of the lacrimal sac was saved around the common internal opening and sutured with subcutaneous tissue or periosteum of the medial side, because it is always difficult to get sufficient mucosal flaps for anastomosis, mucosal anastomosis. Hence, the technically difficult flap making and the suturing posterior flap are omitted in this modified procedure. And 1 ml of 0.4 milligram per ml mitomycin syringing in newly formed passage on 5th post-operative day. And after that, we conceptualized a study, and the aim of the study was to assess the success rate of repeat DCR by a small flap saving technique. And it is an prospective, uncontrolled, and interventional study consisting of 134 patients of failed DCR from March 2011 to August 2021. And all these surgeries done by single surgeons to minimize the outcome bias of the surgical experience. And the incision were made on previous surgical scar, and intervening fibrous tissue were excised, and roughly 1 to 2 mm of the lacrimal sac around common canuculi was shaved, so that the sac remained as a disc with punctum in its middle similar to a funnel. Here A is sac remain, and B is common canuculi opening. Pointer. Here ostium 10 mm Aruga's bone trephine is there, and ostium in the nasal bone and nasal mucosa was made using 10 mm Aruga's bone trephine. And this is Arugan bone trephine along with nasal mucosa. And the remaining anterior part of the sac was sutured with subcutaneous tissue, periosteum of or periosteum of the medial side, and skin was opposed and sutured on 5th postoperative day, syringing of 1 ml of 0.4 milligram per ml of mitomycin C in the newly formed passage. And these all cases were followed up for 1 year. And this is the nasal endoscopy after 1 year, and this is internal nasal opening, that is 4 mm. And these all cases are followed up on 5th day, 1 month, 3 months, 6 months, and 1 year post-operatively. And at each visit, the surgical outcome was assessed anatomical and functionally. And anatomical success was defined as the patency of the newly formed passage on syringing, and the functional success was defined as tearing, assessing using Monk's score. And epiphora of grade 0 to 1 was considered as a success, and the result after 134 patients operated over 10 years is 131%, that is 97.7%. Patients were successful at the end of mean follow-up period, that is 12 months. 2 patients complained of epiphora of grade 2 or more despite successful syringing, and 1 patient failed syringing. And thus our anatomical success rate 133, that is and functional subject 131. And for comparison of this study with previously published studies, we for MedCalc software and the Cochrane chi-square test and inconsistencies were used to assess the heterogeneity among studies. And this is the comparison of success rate with the published studies. And this is the meta-analysis of success rate reported in identified studies on the failed DCR, and the random effect model was used to incorporate heterogeneity in meta-analysis. And this is model showed highest success rate by our study. And this is forest plot depict the study by Wu et al. Can be the source of heterogeneity, and this is symmetrical funnel plot suggestive of absence of bias, and the meta-analysis of success rate shows significant heterogeneity. That is the CIE study, 95% CIE, 76 to 93.33, and p-value is less than 0.001, that is very much significant. And we used here 0.4 milligram per ml of mitomycin C because it is the safest and most effective dose of mitomycin C, and we used 1 ml of 0.4 milligram mitomycin syringing on 5th postoperative days, so that the antifibrotic property of the mitomycin is utilized maximally, as it is not diluted by bleeding from nasal mucosa and better coincides to early proliferative phase of wound healing, which starts from 4 to 5 days of tissue injury. And thus our study, our success rate is significantly better than previously published report despite large sample size. We conclude that and recommend this method because this method is easy to perform, needs no costly instrument, and can be used for mass surgeries. I know this is not for them, but it is born for the masses. Thank you. And I am thankful to Javed Ali from LBP, and ENT surgeon Dhiren, and Lokesh, my aesthetician. Thank you.
So Dr. Ravi, you think your success rate, normally you also use mitomycin in all your DCR cases?
Yeah. In repeat DCR, all the cases I use mitomycin C. Yes. On 5th post-operative day. That's why I call my patients on 5th day of operation. कटा रहेगा तो फेल्ड नहीं होगा, वो पूरा हील्ड रहता है, एंड यूजुअली ड्यू टू सॉफ्ट टिश्यू.
सर दो क्वेश्चन थे. इसमें जो जैसे आपने फोटो दिखाया उसमें नेजल मिकोजा एडिक्वेट है, तो हम ऑस्टियोटमी करके एक बड़ा नेजल फ्लैप लेके आपकी सेम टेक्निक में कर सकते हैं. तो व्हाई यू वांट टू एंकर वो जो आपका सैक का फ्रिल आपने छोड़ा है 2-3 मिलीमीटर जो बताया, व्हाई टू एंकर इट टू पेरिओस्टियम, व्हाई नॉट एंकर इट टू द नेजल मिकोजा?
Initial few cases I felt very much difficulty in doing that. That's why I started by DEW method. This method is by me and I am doing by this method.
जी. और सर दूसरा माइटोमाइसिन सी आप सिरिंजिंग कर रहे हैं.
Yeah.
So conventional thing would be we would apply mitomycin locally and even the published will inject mitomycin से around osteotomy जो आपका published में है.
Sir, that is.
इसमें अगर हम आपके केस में जब आप सिरिंजिंग कर रहे हैं, it is flushing through the entire passage. तो आपने वैसा डिसीजन क्यों लिया? After
5 days everything is healed and a temporary passage is made there, and that's why whenever we will syringe freely it is passing to the nasal mucosa.
नहीं सर, जो कॉन्सेप्ट हमारा एंटीफाइब्रोटिक का है, नॉट ओनली आपने ग्लूकोमा का एग्जांपल लिया. वन थिंग इज देयर इज अ कांटेक्ट टाइम, तो हम उसको 2 मिनट के लिए रखते हैं या 5 मिनट के लिए रखते हैं, जो भी मेडिकेशन है वी फॉलो अ प्रोटोकॉल. सेकंड थिंग इज वी इंजेक्ट लाइक 5FU का आप इंजेक्शन देंगे सेम, क्योंकि आप ग्लूकोमा का एग्जांपल है. When we are putting through syringing,
we are increasing contact time more than 5 minutes.
So आपका फिर वो how do you ensure that contact time? Syringing हमने कर दिया, अब वो flow हो गया, तो उसको आप कैसे ensure करेंगे कि हमारा contact time एक defined रहे उसमें?
नहीं, contact time refined तो रहता ही नहीं सर, more than 5 minutes, क्योंकि 5 मिनट में आपका nasal mucosa में आ जाता है.
जी. उसके बाद आप उसको flush करेंगे, wash करेंगे और leave it syringing?
Generally I don't need it to flush.
And आपका MMC का डोज सिरिंजिंग में लोअर डोज है. नॉर्मली व्हाट वी यूज फॉर DCR इज अ हायर डोज. तो दैट इज
नहीं, that is 0.4 milligram per kg, 0.4 milligram है सर. That is a standard dose, not lower dose.
Not lower dose. 0.04.
Oh.
But question is,
Yeah.
how will you ensure that it stays there for 5 minutes?
0.4% या 4% या 0.04 milligram per kg. Yeah. Ultimately, we are seeing the result. Is there any side effect? No. So that is the novice method, sir. So many things are there to discover. Actually, I have done only 134 patients as yet over 10 years. Actually, my point is कि if we will syringe again, that may decrease the strength of mitomycin C. That's why I am not using at the time of operation.
Usually tears take less than 60 seconds in normal condition to reach the inferior ventral. When we syringe, it takes hardly 5
Up to 5 minutes, sir. A standard is up to 5 minutes.
plus fluid reaches the inferior ventral within 5 seconds. If you just syringe the to the canal. Less than 5 seconds.
नहीं सर, मेरा क्वेश्चन उनसे पूछने का ये था because if it is a standardized procedure, if I want to do, we want to ensure repeatability, and we can always refine a procedure to make it more repeatable and more controlled. That was the question. That's why I was trying to understand more in detail the logic.
सर वो कॉन्टैक्ट टाइम तो इसमें कैलकुलेट कर ही नहीं सकते, हम नहीं कर सकते.
जी ओके. Next person.
थैंक यू.
Next we have Dr. Deepak. हाँ जी सर. Yeah. Next I invite Dr. Deepak. He will present his paper on a study on problems faced by residents in learning and performing external DCR. Dr. Deepak, give us 1 minute to break the
Yeah,
previous.
please.
Hold for 1 minute.
Okay, sir. Chairperson and delegates, first of all, I feel opposed to you because I am jumped in between. In my SSTC area, there is short circuit, so I requested to go for early. My study is on what problem resident face during the doing DCR. As we all know, that DCR is a most common, almost the common surgery in the all the lacrimal surgery status, and mostly in medical colleges or the teaching institution. After some times, only the resident can do, and due course of time, there are various methods which describe various success rates from 80 to 99% from the external DCR. So my aim is to find out what a resident can face or what we can change in the curriculum, because now NMC is also changing the curriculum, and now we are become more and more objective based to perform and know their learning curves. It is a cross-sectional observational study done after taking a ethical clearance between the October 21 to September 22, and inclusion criteria was all the normal cases of obstructions, NLD obstructions, and exclusion criteria, what we can say it is not a difficult case, means what we can say the cases are difficult for doing DCR, we excluded it, that all are the standard pro forma. And after that we created a questionnaire, based on that we'll find out whatever the common steps, in which step they are facing problem. I am skipping these routine processes because these are already done at all the places before doing DCR surgery, and whatever the things we have to do during DCR surgery and after the proper treatment or surgical protocol, we have followed as per the standard guidelines which everywhere is mentioned. So I'm just skipping this and going for the what is the problems they face exactly when they have do, and at which step they are having some problem. Whatever the data we got, we analyze it with SPSS 16 software, and coming to result directly, total 35 responses we got from junior and senior resident both. The age group we all know is the same, and 10 residents from first year, 10 second year, and 10 third year, and 5 were the SRs. We included SR just because they are completed the third year course into the third year group, and we have 3 groups measure of them. And when we do, we find out that whatever the anatomical success rate we defined in our objective aims, it is almost 90% achieved when this surgery is done by the third year, and 75 to 80% achieved when it is done by first year and second year resident. And this is the main table which we are going to highlight, that these are the problems or the things we make as a common leading step in the DCR surgery. In the incision making, yes, out of 10, initially the 2 of the resident from the first year face the incision making problem, but second year and third year usually didn't face. angular vein recognition or some issue related to them. It is again, I am saying, what we can find out is the most common problem in the first year when they are going to recognize. Although these all surgeries are supervised by a trained person, we are going to identify which problem is going on. So initial 3-4 stage problem like incision, angular vein recognition and identification, nasal packing and suturing, all these problems are common in the first year. But from the second year or third year onwards, who had did 25 surgeries, we have taken that in the second year or the third year, these residents at least do 25 surgeries in the first year, then second year, then third year. So after doing 20 to 25 surgeries, these problems are not reported by anyone. Bone cutting is still a problem for the second year, nasal mucosa and cutting of flap, but these two problems again not encountered in the third year when we have means they have done the 50 surgeries. But whatever the fistula is done, but when insertion of the tube or another type of cosmetic problem with suturing and other thing, it is again after doing the 50 surgeries means third year also phase. So we can simply conclude that whatever the anatomical and functional success rate is, that if any resident can get 20, then few steps reduces, next 20, another few step reduces, and what we can recommend, there are the many discussion and study previously done by another authors who shows various type of a number of surgeries should be performed to become say more anatomical success rate or the better one. And we can recommend in our study that 20 to 20 means after doing a 40 to 50 surgeries, the complication rate is significantly low as compared to the first year's one. That is our study, and we recommend that not only 2 or 3 cases, although there may be a surgical hand variation in each and every one, but for the masses, at least 40 to 50 surgeries should be given or should be performed under the observation. Then after only we can give a free hand for any resident to perform the surgery. These are my references. Thank you, sir. Thank you, everyone.
Thank you, Dr. Deepak. So you have analyzed a good one, like relating to the residents. But one thing is that because we have trainers for them also.
Yes, sir.
So I think how many total cases the resident have done by 3 years?
Sir, our places are in our study.
In your study.
Sir, 60.
That is the minimum, or there is a variation for each resident? How many
No,
you
sir.
have taken?
Variation for each and every resident, but what those number of resident we included them, we ideally give equal number of cases in first year, second year and third year.
Okay. Because the main problem here is the flap, where
Yes.
you are creating a flap, anastomosing it.
Yes.
And how about the fistula? I was not clear about it. Fistula.
What, sir?
Fistula. You have written fistula something.
Sir, fistula making means those who have done the that one flap and suturing everyone, they are not able to maintain that nasal flaps and other things. These are the simply the flap related issues, means blockage or the closing that will occur.
So even that includes the skin incision.
Yes, sir. Yes, sir. That anastomosis part is there, sir. That
Yes.
anastomosis,
Yes.
even after doing 40 surgery, the resident faced the problem in that one, lacrimal suturing.
So I think that is a very important criteria to have a success rate, like anastomosis and
Yes, sir.
making of flaps,
Flaps.
and closing it. So
Yes.
that is what gives the success rate for the DCR. If that is not met, I think it is a deficiency.
100%, sir.
Understood.
If we not get the patent path, then how we can assess? But we our
Yes.
so many.
So,
Sir,
so
the aim was only to just know means how much surgery at least we give. That is sir minimum. Maximum is not a criteria. But when we have jump means 20 surgeries, then we find out after doing 40 or 20 surgeries, the complication rate reduces. It is just an objective method because nowhere it is written that everyone is saying complication rate is less in expertise hand. But how much surgery anyone can do to become expertise, that study is basically to just quantify the number so that we can have some idea in that if we can go by this number of cases, then rates will be the come as per our study, sir.
Thank you.
Thank you, sir. Thank you, sir. Thank you. Thanks a lot, sir, for giving me opportunity.
Okay. We have another shuffling up of order. I would apologize to the speakers who are waiting for their turn.
So, shall I start? Good afternoon, everyone. I am here to present the topic of optical coherence tomography imaging of the proximal lacrimal system. I have no financial relationships to declare. The human lacrimal drainage system comprises an upper and lower punctum situated towards the medial end of eyelids. The lower punctum connects to 2 mm section of descending vertical canaliculus before turning medially for 8 mm and join the upper canaliculus and then into lacrimal sac. Our aim was to study whether OCT may be used to image the punctum and proximal canaliculus. OCT image of lower punctum were captured with a Topcon 3D OCT machine. Anterior segment module was used. Single line anterior high resolution scanning was used. 52 puncta of 28 subjects were scanned. The puncta was recognizable on OCT image in all cases. The medial lower eyelid was gently everted to expose the punctum to the OCT scanner with maximum care taken not to distort the anatomy. Canalicular length ranged from 462 to 1242 micron with mean length of 864 micron. Peak width of canaliculum ranged from 126 to 401 micron. Mean width was 234 micron. Punctal anatomy is clinically relevant in the management of epiphora because punctal stenosis is one of its major causes. It is also relevant to design of punctal plugs and assessment of their function. However, there are currently no routinely used imaging modalities or objective quantitative assessment system for the punctal rectimal system. There is currently no other practical way to accurately image the punctal and proximal canalicular morphology in vivo. OCT is a practical and readily available tool in most eye clinics. Its resolution is ideally suited to image of the punctum and proximal canaliculus. Punctal OCT relies on scanners' infrared beam traveling directly through the canaliculus rather than through the surrounding skin. Alignment of punctum and canaliculus with the axis of the scanner's infrared beam is essential. As the wall of the canaliculus often appear to come together in a different shape, and it is difficult to decide at which point to measure the diameter of the canaliculus. However, even the longest canaliculus that we imaged was still much shorter than 2 mm. This suggests that during the resting period, maximum part of the proximal canalicular system may remain in collapse state and it was not being picked up by SD-OCT. Probing with syringe may be similarly unreliable since it may cause dilation of the punctum, thus not giving an accurate representation of patient's normal anatomy. There are no routinely used imaging modalities for proximal lacrimal system. Development of an objective system for imaging the punctum is warranted. So we can conclude that OCT may be used to create a high-resolution image of lacrimal punctum and canaliculus. Further work is required to establish its clinical applicability on a wider scale. These are the references. Thank you.
So last, any questions?
Microcanalicular, no sir.
Microcanalicular endoscope is the instrument through which you can see all the lacrimal system. You can directly visualize in the TV all the lacrimal system starting from the puncta up to the nasolacrimal duct. Even the stone and everything in the canalicular you can observe through this microcanalicular endoscope.
Yes sir.
This is the best instrument to visualize the all the. So this is not easily available, very costly.
Yes sir.
But this OCT, if you can elaborate more in next presentation, that will be useful for all.
Yes sir.
Madam, your last slide, you said it can have clinical application.
Yes.
So as of your presentation, you are only sharing the anatomical data with us. You are not really gone further and applied.
So further works need to be done in this field. It's just an initiative.
So this study is basically an anatomical study of puncta.
Yes sir.
visualize directly with the slit lamp?
So we can visualize it, but accurate and sorry sir, I didn't get your question.
सर पूछ रहे हैं पंक्ता तो वैसे विजुलाइज हो जाता है स्लिट लैम्प पे,
but sir stenos
canaliculi and further things we can't visualize
visualized with the OC.
What your study would add to a physical examination of puncta on a slit lamp?
Yes sir. Yes.
Any questions? Thank you, madam. No. Next. Last नहीं सर, वो सब shuffle हो गया. In fact.
Thank you, Dr. Ruchi.
Thank you, sir.
I would invite next Dr. Marian, and thanks to you for waiting for other speakers. She's between this.
So get 5 marks extra.
Yeah, we'll give extra marks for waiting. Her paper is titled Clinical and Radiological Features of Dacroadenitis in Granulomatosis with Polyangiitis.
Yeah, yes, I thank AIOS for giving me this opportunity. My paper is on clinical and radiological features of dacroadenitis in patients with GPA, granulomatosis with polyangiitis, no financial interest. As we know, GPA or Wegener's granulomatosis is an ANCA-associated vasculitis mainly affecting the respiratory system and the renal system. A variant called limited GPA is there that is affecting the head and neck alone, but orbital involvement can occur in 45% of GPA over the course of the disease, and in 16% of patients this can be the presenting feature. But the diagnosis is very difficult because of the non-specific clinical features, poor sensitivity to ANCA, and wide spectrum of radiological features. More than that, the classical triad of necrosis, vasculitis, and granuloma is present only in 50% of cases. So in this context, we did a study to describe the clinical and imaging features of patients with lacrimal gland involvement secondary to GPA and to compare them with those of idiopathic lacrimal gland inflammation. It was a retrospective interventional case series from 2015 to 2021 in a tertiary care center. Dacroadenitis with biopsy-proven GPA were analyzed. Clinical and imaging features were noted. All the patients underwent treatment and follow-up from rheumatologist also. The clinical features analyzed were lydedema, history of pain, proptosis, ocular motility restriction, and ENT symptoms. Imaging features noted were EOM thickening, intracorneal extension, bone changes, optic nerve involvement, and sinonasal extension. Biopsy-proven idiopathic dacroadenitis was taken as the control group. Coming to the results, in the GPA group, there were 5 patients. The mean age was 35 years. All patients were females, and 4 patients had unilateral, 1 patient had bilateral disease with a mean follow-up of 18 months. Whereas in the idiopathic group, we had 7 patients. Mean age was little high, 42. 4 patients were male, and all patients had unilateral presentation. Coming to the clinical features, in GPA group, all patients had lydedema, and 80% of patients had proptosis with ocular motility restriction. 2 patients had ENT symptoms, mainly deafness. But in the idiopathic group, only 3 patients had ocular motility restriction, a majority had lydedema. Coming to the visual acuity, in the GPA group, less than 6/60 was present in 2 cases. One is due to compressive optic neuropathy, and another patient had exposure keratopathy. But in idiopathic group, all patients are 6/6 at presentation and at final follow-up. Coming to the results of imaging, the imaging features 80% of cases, that is 4 patients had intracorneal involvement, superior rectus involvement, and lateral rectus involvement. 2 patients had globe indentation also in the GPA group. Whereas in idiopathic dacroadenitis group, 5 patients had lateral rectus involvement, mainly in the form of loss of fat plane, but no evidence of any muscle thickening. ANCA was positive only in 2 cases of GPA group. None of the patients had any renal and respiratory involvement over the follow-up. Treatment given was steroids and mycophenolate mofetil in 1 case, whereas the other 4 patients were treated with pulse methylprednisolone, MMF, and rituximab. So this is my second case. She is a 23-year-old female presented with acute dacroadenitis with enlarged lacrimal gland. CT scan showed globe indentation, involvement of superior rectus and lateral rectus. On her final follow-up, she has improved well. She had a alternate convergence squint, was pre-existing. So coming to the discussion, it's a unique study analyzing the clinical and radiological features of dacroadenitis. Only limited literature is available, so this can be considered as a pilot study. GPA, we know, usually occurs in wide population with a peak incidence in the 4th and 5th decades of life. On our study, the mean age was 35 years. Probably this can be considered as a young onset limited GPA. Racial difference also can be postulated as a reason for younger age. But the problem is it causes lots of diagnostic difficulty. Tan et al. In the year 2015 noticed a median age of 37 years. ENT involvement can occur in 6 to 9% of patients with orbital GPA. Bone changes like scalloping, sclerosis, bone destruction, calcification were the main changes in ENT area. But in our study, none of the patients had any bone changes. And the same thing, the absence of bone changes even delayed the diagnosis of GPA. 2 patients had deafness, and both of them had tympanic membrane biopsy showed non-specific inflammation. But lacrimal gland biopsy had more diagnostic yield, and we could diagnose the disease. Usually in GPA, vision loss can occur in 20 to 50% of disease, primarily due to compressive optic neuropathy, exposure, corneal ulcer, eyelid destruction. In our series, even though 2 patients had defective vision, both of them improved, none of them had any permanent loss of vision. Most importantly, radiological features can prognosticate the disease. In our case, all the patients had lacrimal gland involvement, none of them progressed to systemic disease. In a study in 2018, Ismaili et al., they showed diffuse orbital involvement without lacrimal gland involvement had worse prognosis with systemic involvement. ANCA was positive in 40% of cases. This is in accordance with the previously reported literature. So limitations, this is a case series with a limited follow-up, and some of the patients were partially treated before presenting to us. So what this study adds, lacrimal gland involvement, either isolated or with diffuse orbital involvement, can give diagnostic clue in GPA and also helps in prognosticating the disease. Bone changes may not be always present at the initial stages. Lacrimal gland biopsy can be diagnostic even if biopsy from other sites are inconclusive. A high index of suspicion should be maintained, especially in younger patients with repeated ANCA testing, biopsy and imaging were indicated to assess the progression of the disease. These are my references. Thank you.
So what was the follow-up period for this
18
patient?
months. In GPA, only 18 months.
So any complication you noted in that period?
No, other than drug-induced diabetes and rituximab-induced problems.
Okay, right.
Not related to the disease per se.
It was the added systemic condition which was there.
Yeah.
Okay.
Thank you, Dr. Mariam. We don't have any more questions.
Thank you.
Lymphoma with 2 atypical presentations.
Dear colleagues, I would be discussing upon the prevalence, risk factor, pattern and the treatment outcome of severe ROP in Jharkhand. As we all know, ROP is a disease of retinal vascular and capillary proliferation affecting the premature infant who undergo the oxygen therapy. So, it was a retrospective observational study done at the Tertiary Care Center in the Jharkhand. The study evaluated the incidence, risk factor and severity of ROP in relation to the gestational age, birth weight and the treatment modalities, where our inclusion criteria was as per the neonatal guidelines of India: birth weight less than 2 kg, gestational age less than 34 weeks, gestational age between 34 to 36 weeks if exposed to risk factor like prolonged supplementary oxygen, respiratory distress or blood transfusion. The ICROP3 was used to record the stage, location, zones and signs of the plus disease. We have our follow-up first at between the 4 to 6 weeks of life, and the final follow-up was till the retinal full vascularization and the maximum stage of ROP. The data was analyzed using the SPSS software. So our results were, we had a total of 646 infants, mean gestational age was 32 weeks, mean birth weight was 1.6 kg, mean gestational age at the time of ROP examination was 37 weeks. We had more of C-section deliveries, and we had one more correlation, that was the 417 babies were born by the ART, that is the IVF technology. So coming on to the incidence part, 49% babies had no ROP, 21 babies had zone 2 stage 3 plus disease that needed ROP laser, and 15% baby had AP ROP that was treated with injection anti-VEGF followed by ROP laser. and 14% baby had zone 3 stage 1 no plus that were just kept on the follow-up observation. They showed spontaneous regression in due course of time. 1% baby had stage 5 ROP that needed ROP surgery. Coming on to our treatment outcome, among the stage 5 ROP, one baby showed regression with the retina on in the consecutive follow-up. Zone 2 stage 3, those needed ROP laser all show regression. EP ROP, only one needed augmented laser and the spontaneous regression group. So coming on to the result part, the risk factor associated with ROP were lower birth weight, gestational age, and our respiratory distress syndrome. Discussion part, ROP is a serious morbidity of prematurity whose incidence and severity increases with the decreasing gestational age and birth weight. Our finding is not comparable to those from the other study. Being a tertiary care center, we had more of high-risk babies, more IVF babies, so we had a higher incidence of ROP, especially the severe ROP. As we all know that birth weight, gestational age and respiratory distress are well-known risk factor for the ROP. In this study, a lower birth weight, shorter gestational age RDS were independent risk factors for the severe ROP in infants. So we can conclude that high incidence of infants with the ROP in our study emphasize the need for aggressive measures for prevention and control of the disease. The safe implementation of oxygen therapy with appropriate monitoring, better antenatal and neonatal care, meticulous attention to hygienic processes and control of sepsis may reduce the prevalence of ROP. Early referral, adequate treatment, and regular follow-up necessary. These were my references. Thank you AIS for this opportunity.
What was the follow-up in APROP with intravitreal anti-VEGF? How long was it follow-up?
Sir, first follow-up after the anti-VEGF, we did it after 1 week of the anti-VEGF, and then we followed up the child, like after 2 weeks. If the child show improvement, then we follow up him again. But when we show that there is a closer loops or we don't show any improvement in the ROP, then we go ahead with the laser. And we had a final follow-up at least at 52 weeks, and the consecutive follow-up at 3 months of gestation, 3 months of birth, and next follow-up at 6 months.
I hope all the presenters are here and their program is loaded because it's a very tight back-to-back program.
Sir, we had more of severe ROPs in IVF babies especially. That we have another paper, we have presented it yesterday only. IVF babies has more of a severe ROP compared with the normal delivery, those who are born by the National Conception Group. And even in the, that also the aggressive ROP, zone half ROP, all these are severe ROP are more in IVF babies.
So exactly what is it? Exactly what is it? You are the key person opening. Dr. Prakash Marathi will be the one who will open the Very good morning. Very good morning. My name is Dr. Neeraj Rani and I'm presenting the lab assistant to Rick Marco.
Yes, sir. We did the comparison. We had our comparison at every gestational age, like 20 weeks, 24 weeks, and even we have seen that those born after 34 weeks of gestational age, those born by the IVF, they have more of ROP, that to severe ROP, compared with the normal conception, those born by after 34 weeks. Even more than 2.5 kg are showing incidence of ROP in the IVF group compared with the normal conception. So, thank you, sir.
Invariably give us a picture like this, which is completely off the axis. So we accurate, stable, and easy to use Toric marker. We took inspiration from the Goldman's affirmation chronometer.
Good morning, everyone. Good morning, honorable judges. So I'm Dr. Raghunathan, Vitreoretina Fellow from Chennai. And the title of my presentation is Uses of Multicolor Imaging versus Color Contrast Photography in Macular Telangiectasia Type 2. I have no financial disclosures. So as we all know, macular telangiectasia can be identified by blue reflectance imaging, which is a rapid and a non-invasive diagnostic tool that makes use of confocal scanning laser ophthalmoscopy. However, the gold standard to diagnose these signature lesions are color fundus photography. The aim and objective of my study is to describe the various lesions of macular telangiectasia type 2 by using multicolor imaging and to validate them with corresponding signature lesions in color fundus photography. So our study included all patients who had macular telangiectasia type 2, who were all the patients where the diagnosis of all patients were confirmed using reflectance imaging, autofluorescence as well as OCT. So those patients who had coexisting macular pathology were excluded from the study, and of course those patients who had media opacity and poor image qualities were also excluded. So all of the patients underwent color fundus photography and multicolor imaging, and these images were viewed using Heidelberg viewer, and color fundus photographs were simultaneously viewed in the same computer with higher screen settings. All the images were looked for, and various lesions of macular telangiectasia were observed. So all patients, we also observed macular telangiectasia ellipsoid area, which is the maximum horizontal and vertical diameter of the hyporeflectance or isoreflectance in various imaging, and all the images were observed by 2 retina specialists. So these were the various lesions and results. So 48 eyes of 24 patients were included in our study. So 2 patients had poor image quality, and the mean age of presentation was 53 years. So among the various multimodal imaging, macular telangiectasia lesions like yellow crystals and graying were well appreciated in multicolor imaging, while the rest of the pigmented lesions were observed equally in both the imaging. Moving on to the multicolor imaging, the yellow crystals and right angled venule were better observed in green reflectance imaging, while the graying of macula was better appreciated in blue reflectance imaging. With color fundus photography as a comparator, the sensitivity and specificity of MCI to detect macular telangiectatic lesions were more than 95%. However, with MCI as a comparator, the sensitivity and specificity of color fundus photograph to detect these lesions were less than 95%. So coming to the mean diameter, color fundus photography did show lesser mean diameter of ellipsoid area when compared to the multicolor imaging. Among the various multicolor imaging, the blue reflectance imaging did show a maximum diameter area of macular degradation. So of course this I have already discussed. Yes. So discussion, multicolor imaging using multicolor imaging had a better sensitivity and specificity to identify the various macular telangiectatic lesions as compared to the color fundus imaging, and multicolor imaging was better than color fundus photography in delineating the ellipse and picking up the larger area of lesion as compared to color fundus photographs. So of course we conclude by saying that multicolor imaging is an equally efficacious or in was equally efficacious in identifying the various lesions of macular telangiectasia when compared to the color fundus imaging. Thank you so much. Yes, sir. Sir, actually it was a retrospective study. So some of the images were missing, and basically we were trying to look only for those patients who had only macular telangiectasia without any CNVM or other coexistent retinal pathology. Thank you.
Can we have the next speaker, please? It will be Dr. Karobi Lahiri.
occurs within a mean of 70 days, may occur as early as 1 week. The accelerated course differentiates it from the progression of ROP in normal course, and it may be arcuate, pre-papillary, or nasal. Now, we had a total of 106 AROP babies, and we listed it down to 10 babies who had crunch phenomenon. Now, amongst these 26 were referred from neonatologists, which they were by a national progression, and others, 27, were referred from ophthalmologists, which was as the second or the third opinion. So this was the data analysis. There were more females than males, and it was ranging maximally in the 28-weeker group. 16 were bilateral, 2 were unilateral, and the prevalence was more in the 800 to 1,000 age group. Now, in the data analysis, we found that laser was done in half and not done in half. And in the injections, the 9 patients were of ranibizumab, bevacizumab, and 7 were from ranibizumab injections. So the data analysis also showed that less than 7 days in one patient, it occurred between 1 to 4 weeks in 2, and greater than 4 to 8 weeks in 7. Now, out of the 54 AROP babies, 10 infants, that is 18 eyes, 2 were spared, all had anti-VEGF injections for battling ROP, occurred bilaterally in 8 patients and unilaterally in 2 patients. And when referred from the neonatologist versus referral from ophthalmologist, we found that it was a statistically significant figure. And this is the case series. There were 2 who regressed after the laser, so they were not in this fray. And the others had a combination of either laser and injections as well as surgeries in some. So only fill-in barrier was given in 3 children. Fill-in laser with intravitreals in 8 patients. Fill-in laser with intravitreal followed by surgery in 6 patients. Stage 4 surgeries in 2, stage 5 surgeries in 2, and best left clone eyes were in 2 cases. And out of the 18 eyes, we found that 13 did well and 5 did not do well, they were lost. So this is a half zone ROP, which you see in that thing. There's hardly any, this right up to the arcades. And this is another case of crunch, which you see on the right side, and the laser done. So the results is that out of 18 AROP eyes developed crunch phenomenon. On comparison of results, we found that the direct referral was more statistically, the referral from the ophthalmologist was definitely more than that from a neonatologist, and of which 18 AROP eyes with crunch phenomenon, 13 did well, that is 72.22%. Quiescence was seen in all of them, and 5 eyes did not have this. So on comparison of results of AROP with crunch phenomenon, present or absent versus status of disease quiescence was again seen to be statistically significant. There were surgical dilemmas because these were elastic, tenacious, and fibrous, multi-layered, and surgical approach was directly from the disc towards the periphery. And the prevention was the most important thing because this happened in AROP babies. So don't be fooled by apparent disease quiescence. ROP crunch mostly occurs in AROP eyes. Careful, timely close-up, and better to follow up anti-VEGFs with laser by 3 weeks or 4 weeks. Anti-VEGFs preferably avoided in advanced stage 3 or stage 4 cases. Aggressive surgical treatment recommended in all these diagnosed cases. Thank you so much for your kind attention.
That's a nice presentation, Dr. Karopi.
Thank you.
So one question. Was there a correlation between worsening of the weight or any other systemic diseases to the crunch which happened? Was it the same? Was it the same?
No, I didn't get your question. Worsening
so
of?
the baby, you're given injection, and we expect the babies who gain weight and who become systemically better, they fare well. Were these patients who had crunch? Was there a correlation that was it because of the deterioration of the systemic or its injection alone? Was there a correlation?
Yes, we had a total of 106 eyes, that is 54 babies, out of which there were only 20 who had landed up with crunch. Now these came in different time zones, means when they were referred as a second and third referral, by that time the child was a little older. because they were seen by an ophthalmologist, given the injections over there, landed up with crunch, and then they were sent. So the thing is that the time frame was a little different. By that time, the child was not in the NICU, the child was out of the NICU at home, so there was no involvement of any kind of systemic problems at that point of time when we did see these children. And the ones from the neonatologists were ones which I followed up from 3 weeks onwards. So those were the children
That's
who
what
were
I meant.
treated
If you
for
had
systemic.
included only primary referrals, it would have given, because when the patients are referred from outside, you might miss out on that. During that 1 month was there a stormy period which can give rise to this?
No, they were all AROB babies. So they were very stormy, these babies. They had like a 360 zone avascular retina, and they had been given the injections maybe at 3rd week, 4th week. But on the follow-ups, probably the follow-ups were not done on time. And when the patient landed up, means you have a disease quiescence, it looks good. So the patient goes to the to the ophthalmologist, he says, everything is fine, but the blood vessels have not touched the periphery. Then suddenly they go after 2 or 3 weeks and boom, the whole thing comes up again. So that's how they were sent as the second and third referral.
Is it possible that the babies received the first treatment itself late in these cases, when they already had some amount of beyond stage 3 and excessive fibrosis?
That's what I said. Some of them were injected at advanced stage 3 also.
That could probably another contributing factor.
It could be, yeah. We didn't get into the logistics of what somebody had done. We just got into the logistics of the crunch effect which occurred later.
The discussion can go on. Just for the want
Thank
of the
you.
time, can we have the next presenter, please? Can we have the next presenter? It will be Dr. Anubi Paharia. After her will be Dr. Praneeth Telakunta. Can I have the presentation, please?
Hello, good morning to all. I will be presenting SDOCT based imaging biomarkers for visual prognosis in eyes with macular edema secondary to retinal vein occlusion. So coming to the introduction part, briefly I will be describing retinal vein occlusion is a common vascular disorder of retina and one of the most common cause of vision loss worldwide. It is the second most common cause of blindness from retinal vascular diseases after diabetic retinopathy. So occlusion can be divided into central retinal vein occlusion or hemiretinal vein occlusion depending upon the site of occlusion. It is significant that anti-VEGF strategies involving intravitreal injections have become a part of mainstream therapies for macular edema secondary to retinal vein occlusion. There is a marked decrease in macular thickness after the therapy, but there may be chances that there are no improvement in the best corrected visual acuity, which suggests that macular thickness is only one factor out of several factors which affect the BCVA. So reason for limited visual acuity may include macular ischemia, photoreceptor dysfunction, accumulated subfoveal hard exudates, and disruption of inner retinal layers. So SDOCT now comes into a main factor which is a high-speed, high-resolution cross-sectional 2D image and is a powerful tool for the non-invasive assessment of retinal physiology. It also appreciates the individual layers and thus helps in the quantitatively analysis of all the layers. Despite the clinical relevance, this findings clinicians frequently have observed that eyes with poor visual outcomes, regardless of the complete resolution of macular edema, there are certain other factors which contribute to it. So for this, we studied the SDOCT based parameters which included the integrity of inner retinal layers, including the inner nuclear and plexiform layer, ellipsoid zone disruption, and external limiting membrane disruption as the factors which can contribute for the decrease in not improvement of BCVA even after giving the anti-VEGF injection. So material and method we included the treatment naive eyes with macular edema secondary to retinal vein occlusion. This was a hospital-based prospective observational consecutive case study. The sample size was 64. There were certain inclusion and exclusion criteria. Briefly describing about the inclusion criteria, we included treatment naive RVOs who had not gone for any other treatment before and were ready to give consent and the age above 30 years. Whereas the exclusion criteria were significant media opacity, history of cataract surgeries, any other confounding retinal diseases, history of any other previous surgery or pregnancy or any intravitreal injections. Approach to the patient was history was taken in detail, systemic examination was done, ocular examination with visual acuity examination, SD-OCT was done on baseline after 1 month of injection and after 4 months of injections. There were 3 consecutively intuitive injections which were given. Imaging modality which included was for each eye the scan passing through the foveal center was selected along with the 3B scan immediately above and below the fovea for a total of 7 scans with a 170 micron apart and a vertical height including of 0.72 mm. The SD-OCT parameters which were studied were disorganization of retinal layers, disruption of ellipsoid zone, disruption of external limiting membrane, central macular thickness and hyperreflective foci. Coming to the discussion part, in our study 53% had BRVO including ST and IT BRVO, and in bivariate analysis we could find out that the changes in the following parameters, the drill and drill size was found to be significant after the anti-VEGF injection. In multivariate analysis, the whole cohort for each study group only change in drill size is significantly associated with change in visual acuity from baseline to 4 months post anti-VEGF. By using general linear regression formula, we found that an increase in drill size of around 90 micron is associated with reduction in 0.1 logmar in visual acuity. We did even a predictive model study which could predict that there is a significant association between predictive visual acuity and actual visual acuity. This was the chart which depicts all the parameters. And concluding for this, that there is a great extent of drill which is responsible for reduced visual acuity. This finding is explainable as disorganization represents a loss of bipolar amacrine or horizontal cells within inner retinal layers, which are important cells for transmission of visual data from photoreceptors to retinal ganglion. Further, in the predictivity model, we found that an increase in drill size of around 65 micron can predict a 0.1 logmar visual acuity at the end of 4 months. We also studied secondary outcomes like age, diabetes mellitus, hypertension, duration of hypertension and type of hyperlipidemia, which did not come to be significant. Thank you.
Just a practical note, among all the biomarkers, which one do you think is the most significant for an ophthalmologist to see whenever monitoring any macular edema?
Sir, the most important biomarker which we see is the ISOS junction disruption basically. But if that is there, that means the visual acuity or prognosis of the disease after even injection is little poorer towards side. But in my study, the drill and drill size come to be associated with it. If there is increase in drill size, there was decrease in the logmar visual acuity after the injection.
Thank you.
Thank you.
Yeah.
The next presenter after Dr. Praneeth will be Dr. K.R. Chakrabarti. Please be ready.
Please stick to time. Post your podium is 3 minutes and you cannot run over into the next session.
Please start.
Yeah. Good morning, everyone. I'm Dr. Praneeth Terlukunta. I will be presenting on the phenotypical variation with age in ceramide kinase like protein related I'll be presenting on the phenotypical variation with age in ceramide kinase like protein gene related retinitis pigmentosa in a single family. So we know that among the inherited retinal dystrophies, retinitis pigmentosa is the most commonest, and based on its heterogeneity, it is very complex in its phenotypical variation. The objectives of my presentation are to understand the various phenotypical presentations at different ages in circle gene related RP patients, and to differentiate these phenotypic findings from the other typical RP phenotypes. So the first case is of a 10-year-old boy who came with complaints of reduced central vision from the age of 6 years. The best corrected visual acuity was 20/80 and N10. On further history, there was no night vision or peripheral vision problems. The fundus examination showed mild arterial attenuation and central macular atrophic changes. The fundus autofluorescence showed a hyperautofluorescence ring at the macula, and the OCT showed there is loss of photoreceptors layer. So the full field ERG showed extinguished responses with reduced responses of rod cone amplitudes. So based on this, we came to a provisional diagnosis of retinitis pigmentosa with macular involvement, cone rod dystrophy, and Stargardt's dystrophy. This is a 5-generation pedigree charting showing a kind of equal affection of males and females, so showing autosomal recessive inheritance. So clinical exomic sequencing directed towards the retinal dystrophy panel was performed based on the history and the clinical findings. So we came to a diagnosis of circle gene related retinitis pigmentosa, as there was a frameshift deletion of exon 7 on chromosome 2. This is the second patient who was the mother of the 10-year-old child, and she complains of decreased central vision since childhood, and on the second to third decade there was decrease in the peripheral vision as well. Her vision was hand movements, and here we can see that there is pallor of the optic disc, there is arterial attenuation, macular atrophy, bony spicule pigmentation, and also the chorioretinal atrophic changes. And the findings of fundus autofluorescence also they are going in favor of the typical RP changes. There was also loss of photoreceptors on the OCT. This is the third patient who was the nephew, and he was the first cousin of the 10-year-old child, that is the case 1. He had findings similar to the case 1. There was also one more patient, she was a 42-year-old female, and she had findings similar to case 2. So what have we seen commonly in all these patients is the macular photoreceptor affection and the severely affected full field ERG. And in younger patients, what we have seen is the mild or no disc pallor and minimal arterial attenuation. And common to older patients was the prominent vascular attenuation, total central and macular atrophy, bony spicule pigmentation, peripheral scalloped chorioretinal atrophic patches. So in comparison to the typical RP, the circle gene associated retinitis pigmentosa shows early macular involvement, paucipigmentary changes, and scalloped chorioretinal atrophic patches in the later age. So these are the take clinic messages I would like to underline. That is, a circle gene related retinitis pigmentosa shows a wide spectrum of phenotypical changes at different ages, varying from early macular involvement and paucipigmentary changes in the first decade to severe macular atrophy and typical RP-like changes later. And knowledge of this changing phenotype due to the circle gene from early to later part of their lives helps in appropriate diagnosis, early visual rehabilitation, and career counseling. So this present family, it highlights a crucial role of the genetic counseling and testing for future generation risk assessment. That's all for my presentation. Thank you all for the patient listening.
Very good presentation. So don't you think that the findings in the older patients were a progression of the changes over lifetime?
Yes, doctor. That is what I wanted to highlight in this case series, that at the younger age there was no severe typical presentation of RP, and this should not be confused with other dystrophies, because in this there is progression, and that would help in the future counseling the patient for future planning.
All RPs would show progression, majority
Yeah.
of them. What differentiates your cases is the early macular involvement, whereas
Yes,
in most other RPs you would get a later macular involvement.
Yes, doctor.
Good presentation.
Thank you, doctor.
Thank you. Can I have the next presenter, please? Dr. Anubi, are you a ratified member? Because here it's mentioned anyone beyond 26065 not ratified. Yours is 260. Oh yeah, sorry. Yeah, thank you. Sorry. Please go ahead.
My talk will be on the complications following combined pars plana vitrectomy and Ozurdex implantation. Pars plana vitrectomy is an established and safe surgical approach for the treatment of many retinal conditions. This procedure is, however, not without its complications, mostly because of postoperative inflammation. During PPV, preservative-free triamcinolone acetonide helps in reducing the incidence of postoperative inflammation. However, because of the short life of this drug, it cannot be used long-term. This is where Ozurdex comes into play. It stays in the vitreous cavity for up to 6 months, and it has a similar pharmacokinetic profile in both vitrectomized and non-vitrectomized eyes. Our study was to assess the postoperative complications associated with combined pars plana vitrectomy and intravitreal Ozurdex implantation for a variety of posterior segment pathologies. Our study is a retrospective observational study between October 2021 and May 2022. 25 patients who underwent combined PPV and Ozurdex implantation were taken up. Complications in the intra and postoperative periods up to 3 months were followed. Complications were defined as implant migration into the anterior chamber, worsening of visual acuity by 2 lines or more, increase in intraocular pressure by more than 5 millimeters of mercury from the preoperative baseline. Details of the patients were collected from the electronic medical records. These are our results. 18 of our patients were phakic, whereas 7 were pseudophakic, 2 of which had SF-IOL and 1 had iris claw lens. These were the indications of our surgery. Best corrected visual acuity. Preoperative vision ranged from hand movement to 6/24, and there was significant increase in visual acuity 3 months post-op. In 9 patients, intraocular pressure rose to mid-20s and was started on anti-glaucoma medications. They were well controlled, and the medication was tapered 3 months post-op. In 1 patient, the IOP raised to 30 millimeters of mercury. It was also controlled. Central retinal thickness. There was a significant decrease in central retinal thickness by 3 months post-op. However, recurrence of macular edema was noted in 6 patients. Anterior migration of the implant. This was our most important complication, and it was noticed in 2 cases, one with iris claw lens and another with SF-IOL at 2 weeks and 1 month postoperatively. The implant had migrated through the pupillary space between the iris and the IOL. These are the studies that were similar to our studies. In a study done by Zheng et al., findings were similar except that they did not notice any anterior migration of implant. Study done by Kang et al., in 24 eyes studied, there were 4 anterior migration of implant, whereas in our study there was only 2. Khurana et al. Postulated that the absence of lens capsule and prior vitrectomy were risk factors associated with the anterior migration of implant. Our study is not without limitation. One is a small sample size. Second is a selection bias because patients with complicated vitreoretinal pathologies were included, and there was no age and sex match controls. To conclude, combined PPV and Ozurdex implantation, even though a safe procedure in controlling both postoperative inflammation and macular edema due to various pathologies, is not without its complications. The most significant postoperative complication associated with the combined procedure was anterior migration of the implant. Thank you.
Yeah, nice presentation. So, in your own study, in your institution, was there a difference between Ozurdex injection not during vitrectomy, Ozurdex injection in SFO or iris claw patients versus combined with vitrectomy? And was there any change in the migration? What I'm asking is vitrectomy has something to do with migration versus the SFO iris claw itself is a risk factor?
Yes,
was there a comparison?
No, sir, it was not compared, except that in a study done by Khurana et al., it was postulated. Because all the patients that we took were vitrectomized patients. So, if you had taken a sample size, like if you had taken controls, maybe with only Ozurdex and then with only pars plana vitrectomy, then we could have come to a conclusion.
What I'm trying to point out is the pseudophakia with PC defect itself is a risk factor.
Yes, sir.
So, in your study, what is it that you are trying to say? Like vitrectomy is the risk factor itself?
No, sir. It is because there is the absence of PC only, because of which the migration can be easier into the anterior chamber.
Thank you.
Yes, sir.
Can we have the next presenter, please?
Symptomatic floaters. So floaters is one of the most common presenting complaint, and persistent and symptomatic floaters can cause a significant quality of life loss in the patient. So here we study the safety and efficacy of 23 gauge sutureless vitrectomy in symptomatic floaters in pseudophakic eyes. We included long-term symptomatic patients had given informed consent, and we excluded those patients who had other systemic or retinal pathologies. So the technique was a core vitrectomy with removal up to vitreous base. In those cases, PVD was not there and induction of PVD was done, and at the end, extensive search for retinal breaks was performed. There was up to an 18 months follow-up. The mean age was up to 63 years, more number of women than men, and PVD was one of the most important etiologies, and asteroid hallucis was another etiologies. So the mean visual acuity improved from 618 to 6.9 in our patients. So there was a good improvement in visual acuity. The quality of life survey also showed good improvement, with almost 96% patients showing satisfaction and 85% patients experiencing a complete success. 80% of our patients had completed the survey. The complications were presence of a retinal tear, but not in a patient whom PVD was induced. So retinal tear was present in a patient who had already a complete PVD, but it was an iatrogenic retinal break. So 2% had an iatrogenic retinal break. Transient complications like CME and vitreous haze were present in one eye and two eye respectively. However, both had complete resolution and a good improvement in visual acuity. None had RD post-op or end-off or choroidal detachment or hypotony. So our study, wherein we did a sutureless vitrectomy, showed a good decrease in the symptoms for the patient, that is improved quality of life. In this, we had a sutureless vitrectomy, because of which the surgical time was less, post-op inflammation was less, and hence recovery was quite rapid. So statistically significant improvement in visual acuity was present, and all our patients had initially impaired quality of life with improvement in the quality. There were low complication rates. Only one patient had retinal tear, and which was comparable, and there was no difference in retinal tear formation in those who had a PVD previously and did not have a PVD. So in all, sutureless vitrectomy in those who are symptomatic and who have been given a chance, that is, we waited for the patients for up to almost an year or so before we actually intervened surgically, had a high satisfaction. There is a limit. There are limitations to this, because there can be a selection bias, because we were this was not a randomized controlled trial. Limited patient population, that is small size, and difficulty in determining the presence or absence of PVD. The patients in this study underwent a survey many months after the procedure, and so recall bias can be an important thing. So patients with an active lifestyle who had a poor quality of life can be considered as ideal patients. As vitreoretinal specialists, we should give them an option to undergo treatment for PVD, because we many times just ignore PVD in our OPD and tell them that come again later. Thank you. Yes, we counsel, we wait for an year before we actually intervene. We wait, we ask them don't undergo operation as a first choice, but if anyone is actually impaired too much, especially if the floater is coming in their field of vision, if their visual acuity is getting affected, then only we intervened in this case.
Thank you.
Thank you.
Can we have the next presenter? Dr. After Dr. Jitendra Singh will be Dr. Joglekar Mandar Atul. Is he here? Okay.
Good morning, everyone. I'm Dr. Jitendra Singh, Senior Resident, Medical College, Prayagraj, presenting on comparing RNFL thickness in chronic kidney disease patient and healthy controls. Start with the introduction. Chronic kidney disease is a metabolic disorder affecting the kidney and in function. OCT uses a low coherence interferometry and ability to detect any change in retinal nerve fiber thickness. Ischemia in CKD patient affect the retinal microvasculature, resulting in decrease in RNFL thickness. Thickness of RNFL vary at different stage of neuropathy. What we have included cases of age more than 18 having a CKD were included in group A, and age-matched control was selected from the healthy population included in group B. It is an observational study, and 150 eyes were taken in each group. We included any ocular pathology, glaucoma, age-related, and any retinal pathology, history of any ocular injury, intraocular surgery, laser surgery, poor media clarity, and cooperative patient not giving consent. What we have found, we divided into two groups. 75 we have CKD, and group B age-mate control. We do not have the CKD disease. Mean age was 47.72 group A and 47.36 in group B. And out of the 75 patients, 23 males, 52 females. Majority of CKD patients were on hemodialysis. 45 patients out of the 75 patients. What we have found, we found through this table, group A we have a CKD patient, group B we have age-met normal control. The mean RNFL thickness was studied to be thinner in group A in comparison to group B. This is a bar diagram which signifies statistically significant thickening was noted in the superior and the inferior quadrant in group A. And this is a comparison of mean average RNFL thickness between hemodialytic patient and non-hemodialytic patient in group A, and we have found that statistically significant increase in thickness was found in hemodialytic group. This is a comparison of mean RNFL thickness in various stages. Mean average RNFL thickness found to be thinnest in CKD patient stage 5, followed by 4 and 3. A discussion in present study, mean RNFL thickness was analyzed for temporal superior, nasal superior and inferior quadrant. Both the groups were compared and changes observed were statistically significant in superior and inferior quadrant. What we conclude in a study, mean average RNFL thickness was significantly thinner in CKD patient as compared to non-CKD patient. Statistically significant thinning of mean RNFL was noted in superior and inferior quadrant. A statistically significant RNFL thinning was noted in nasal quadrant with advantage age. A statistically significant thickening of average mean RNFL was noted in hemodialysis group as compared to non-hemodialysis group. A negative correlation was seen when mean average RNFL thickness was compared to duration of CKD. Thank you.
Yeah, nice presentation. Any correlation between your RNFL findings and the renal function test? Try to investigate.
No, sir. Renal function test. We have found renal function test. What patient who are categorized as
creatinine levels.
With the creatinine levels. We have not matched. We have divided into two groups, CKD non-group, but not with the creatinine levels.
Thank you. Nice presentation. So, can we have Dr. After him, the last presenter will be Dr. Sumit. Dr. Sumit is here. Dr. Sumit is here.
See post. I'll put it here. Yes, I just want to present my initial experience with the fovea sparing ILM peeling in the vitrectomy for proliferative vascular diseases. So ILM peeling in vitrectomy for proliferative vascular diseases is practiced mostly to remove the macular folds and reduce the chances of reproliferation. However, there are problems like foveal thinning, foveal drag towards the disc, and paracentral holes. So they have been highlighted in many studies. So, foveal sparing ILM peeling is recommended in myopic foveosis cases in by many authors. So, can we apply the same in vascular proliferative diseases? So, we did an retrospective analysis with inclusion criteria of cases undergoing vitrectomy for proliferative diseases between February 22 and June 22. All those cases underwent fovea sparing ILM peeling were included. The follow-up was less than 3 months was excluded. Cases with combined RDs were excluded. So ILM peeling technique involved curvilinear peeling, a U-turn or a circle back to avoid the foveal peeling, and doing the flap and trim. And most of the cases were done, all of the cases rather were done by the combination of two or more of these techniques. We analyzed the demographic data, analyzed the OCT images pertaining the macular thickness and foveal contour, and compared the final best corrected visual acuity at 3 months. So there 8 cases were included, 5 males, 3 females. Mean age was 46 years. The diagnosis was PDR is most common, BRV, and one case was EELS. So we found 4 types of contours. One was well-maintained contour. One was wavy contour but well-maintained foveal depression, persistent macular edema in one case, and moderate foveal thinning. So well-maintained counter was seen in 3 cases, foveal thickening was seen in 3 cases, and macular edema was seen in 1 case. Final visual acuity is presented. Majority of the cases lie between 618 to 636. So subjective observations where the visual acuity is better preserved than generally observed with conventional cases. Foveal contour was generally well maintained, better than the observed with full ILM peelings. Problem with foveal thinning and persistent macula are still seen in foveal sparing peeling, and no specific surgical technique related complication was encountered. Thus the foveal sparing ILM peeling was generally safe as a technique. Foveal contour was maintained in many other cases. We need larger studies, larger series with comparative study to actually go ahead with this study. Thank you.
Nice presentation, Dr. Atul. What is your hypothesis?
The hypothesis is the fovea, ILM is there to maintain the integrity of the fovea. The absence of ILM may lead to the foveal thinning or dragging of the foveal area. So if you just, the hypothesis is the same as what is there in myopic foveoxisis. It's the same hypothesis applied here.
I mean, what was your indication for ILM peeling? Like routinely you peeled ILM in
all cases with having a macular folds basically, which are not removed by just simple ERM peelings.
I know, but in your cases macular hole was not there, right?
No.
So that's what is the indication for ILM peeling is what I'm asking.
Is the remove the macular folds which are not removed by the removal of epiretinal membrane alone.
Okay, but the case which you showed did not have macular fold. That was a very well stained ILM with, there was not even no ER.
There are some ILM folds there. Folds were there, not.
Because ideally, if you want to prove that inverse peeling or the foveal peeling helps, then you need to have the study design has to be like in one group you have to peel.
Yes, agree.
Another group.
Agreed. That's what I'm telling you. It's just an initial experience. It's not a full-fledged study.
Anyways, nice presentation.
Yeah, nice presentation.
Question? Session. Thank you everyone for sticking to your time and nice presentations. Good learning. Yes, the presenters can come over on the stage. We can have a picture.
Dr. Rima Bansal is there, so we'll start with Dr. Hitisha Mittal. And there are two candidates, Hitisha Mittal and Abha Gupta, under Dr. Rima Bansal. अभी से आगे आप बात करें.
Timer. Should I start, sir?
Yes, start.
Good morning, everyone. Saving sight and life in retinoblastoma is of paramount importance for the patient as well as his family. It is the most common. Sorry, it's not working. Morning, everyone.
This is for the mentors.
Timer.
Have they told you
Abhi band kar
this period of time they have to present for? 4 minutes and 2 minutes of discussion. 1 minute of discussion. Only question answers. The panel comprises of. Okay, and what about the?
What is the role of mentors?
Okay. Why don't all the mentors come and sit in front? Vaishali, you're a judge, no? Hatu, you come and sit here in the front row. Whoever is a judge, come and sit on the front row. This is all categorization. Okay. So they don't have to be on the dais?
Please start.
Good morning, everyone. Saving sight and life in retinoblastoma is of paramount importance not only for the patient but for his entire family. It is the most common ocular malignancy of childhood with an incidence of 1 in 15 to 18,000 live births and an average age of presentation of 18 months.
It's a potentially lethal disease due to CNS spread or hematogenous metastasis. However, with adequate treatment, there's a 79% survival rate in countries like India. It occurs due to a mutation in the RB1 gene on chromosome 13, and nearly 30 to 40% of the cases are heritable with the autosomal dominant inheritance pattern. The non-inheritable retinoblastoma have both the hits in the retinal cells postnatally and result in a unilateral retinoblastoma. Now, when do we suspect retinoblastoma in a child? The most common presentations include leukocoria, strabismus, a red painful eye, and poor vision. If left untreated, it can invade the orbit and present with proptosis and a fungating mass. It is important to remember to look for a posterior segment mass lesion in children with congenital cataract to avoid inadvertent entry into the eye. Now, how do we approach? We approach with a detailed history, examination, imaging in the form of B-scan and MRI, then grouping the disease followed by parental counseling regarding the treatment options. Now, the important findings to be noted on EUA include a pseudohypopaeon, a subretinal mass or a mass projecting into the vitreous cavity, and seeds at various levels in the eye. All these findings need to be documented properly on an Amsler-Dubois chart so that these patients can be followed up after commencement of the treatment. Now, ultrasound helps us in locating the mass lesion, presence of calcifications, and measuring the dimensions of the tumor, which help us in grouping the disease. MRI orbits and brain. MRI orbits help in knowing the extraocular extension, optic nerve infiltration, CNS invasion, and presence of pinealoblastoma. Retinoblastoma lesions are hyperintense on T1 weighted and hypointense on T2 weighted MRIs. Now, based on this, we classify them according to the international classification and plan the further treatment. Our primary motive is to save life, followed by globe salvage, followed by vision salvage. It is important to take care of visual and cosmetic rehabilitation, screening of the siblings, as well as genetic counseling of the parents. Now, there are different treatment modalities present in today's era, which includes chemotherapy, focal therapy, radiotherapy, as well as surgery. Which treatment to give depends on each individual case. The lesser advanced tumors can be treated with a combination of intravenous, focal, or plaque therapies, whereas advanced ones can be treated with intra-arterial and enucleations. Now, intravenous chemotherapy is the current day primary mode of treatment for retinoblastoma, and it may be supplemented with an intravitreal chemotherapy or an intra-arterial chemotherapy to achieve higher intraocular drug concentrations. Focal therapies are for smaller tumors as an adjuvant to intravenous therapy. It can be in the form of cryotherapy, a transpupillary thermotherapy, as well as laser photocoagulation. Episcleral plaque therapy is also used as a mean of focal treatment, and post-enucleation eyes can be treated with external beam radiation therapy if histopathology is suggestive of high-risk features. Enucleation is reserved only for advanced intraocular and extraocular retinoblastoma. We should avoid globe perforation intraoperatively and harvest a long optic nerve stump. If histopathology is suggestive of high-risk features, these patients should receive adjuvant treatment post-operatively. So this is how we can save the sight and life in retinoblastoma. This was an 8-year-old child who presented with group D RB. She received treatment in the form of intravitreal and intravenous chemotherapy, and post-treatment there was complete regression of the disease with a visual acuity of 6/60. Thank you, and I would like to thank my mentor, Professor Reema Bansal and AIOS for this opportunity.
What is the role and indication for neoadjuvant therapy?
Sir, if there's, we know there's an extraocular retinoblastoma at presentation, we can give neoadjuvant chemotherapy, reduce the disease burden, and then we can do an enucleation.
Were there any masquerades that you saw?
Ma'am, we have to look for other causes of leukocoria, like it can be Coats disease. It needs to be differentiated from Coats disease. There can be persistent hypoplastic primary vitreous, and it's commonly confused with congenital cataracts. And also we should look for toxocariasis, however not so common in our part of the country. So these should be looked for in every child with leukocoria.
How do you differentiate between Coats disease and retinoblastoma?
Sir, in Coats disease, there is no specific mass lesion, there are no calcifications, and there are telangiectatic vessels up to the peripheral retina, which is not so common in retinoblastoma.
How what is the genetic marking? Genetic marking?
Sir, it is due to RB1 gene mutation, and it's an autosomal dominant pattern, so both children and parents should be screened for it.
What about the status of the other eye?
In the representative case, ma'am, the other eye was group ERB, so she underwent primary enucleation for the other eye elsewhere before presenting to us. She presented to us with the right eye, group DRB, so we managed that eye. The other eye orbit was healthy.
When you give your adjuvant therapies along with cryotherapy, or do you do a laser, or or you give a subtenance injection, what do you manage with?
I'm sorry, I didn't understand.
When you're treating these cases,
Yes, ma'am.
you give them chemotherapy?
Intravenous chemotherapy,
Right.
yes, ma'am.
You give them adjuvant therapy for the eye in the way of what? Cryotherapy, laser?
Ma'am, if they are anterior to, the tumors are anterior to the equator, we can do a cryotherapy. But if they are posterior and small, less than 4 mm in apical height and less than 2 mm in basal thickness, we can do a transpupillary thermotherapy using infrared radiation, or a laser photocoagulation using green laser, 532
And in the
nanometers.
patients who had vitreous seeds, did you feel there was a regression following your chemotherapy and the adjuvant therapy?
Ma'am, vitreous seeds are the most difficult to treat. They do not respond to intravenous chemotherapy because they do not have a blood supply. So the chemotherapeutic drugs that we are giving systemically, they do not reach the vitreous seeds. So for vitreous seeds, intravitreal chemotherapy has a very high role these days. They respond dramatically to intravitreal chemotherapy.
And how many patients did you give subtenance carboplatin?
It's not commonly practiced in our center. Subtenance, I have not seen. Thank you so much, ma'am. Thank you, sir.
A very good morning to all. So I would first like to thank my mentor Dr. Kasturi Bhattacharya madam for giving me this opportunity. So we are the teachers today and we are going to take a class on phakic intraocular lenses. So starting off, to correct refractive errors, there are 3 anatomic possibilities: the corneal lens, the crystalline lens, and the space in between them. Now, cornea-directed procedures are related to multiple complications associated with wound healing, a reduced quality of vision, and obvious limitations when it comes to high degrees of ametropia. For refractive lens exchange, there's a loss of natural accommodation, and there's a loss of the crystalline lens barrier, which can cause VR side effects. Now, phakic IOLs forego the risk of corneal ectasias. They preserve the crystalline lens barrier, they're reversible, and they give a better subjective quality of vision. The evolution of phakic IOLs went on from the angle fixated IOLs to the iris claw IOLs, and now the currently in vogue posterior chamber phakic IOLs. So this is the cachette, the last of the angle fixated IOLs. Now this went out of vogue for multiple complications, but mainly because of the endothelial damage they caused and the pupil ovalization. This is the iris fixated IOL. Now this is enclavated onto the mid-peripheral iris stroma with the help of a claw haptic. What these did is they caused iritis, an atrophy of the iris, and loss of the enclavation. So there was a free-floating IOL in the anterior chamber that led to endothelial cell loss, among other complications. Coming to the most important part of today's discussion, the posterior chamber phakic IOLs, in particular the implantable colamal lens. Now this is made of a polymer of porcine collagen and hydrophilic acrylic material, and this material is important because it attracts fibronectin and it is an immunologically inert material. Now it's inserted into the ciliary sulcus between the iris and the ciliary body. We'll look at some of the important criteria for implanting phakic IOLs. A stable manifest refraction, ametropia that is not correctable with excimer laser surgery, an adequate anterior chamber depth of around 2.8, preferably 3 millimeters, an adequate iridocorneal angle aperture, endothelial cell count, and no pre-existing ocular pathology. So the IOL power calculation is based on multiple nomograms, but mainly the Van der Heide nomogram for anterior chamber phakic IOLs and the Binghorst nomogram for the posterior chamber phakic IOLs. Sizing is the absolute key for ICL implantation. Now sizing is based, the FDA approved method is wide to wide distance, and it is calculated based on so digital calipers are used pre-operatively on a slit lamp, and the sulcus to sulcus distance is calculated from this wide to wide. However, the direct measurement of the sulcus to sulcus distance has also been debated, and that can be done with the help of ultrasound biomicroscopy, ASOCT, as well as Scheimpflug imaging. So this is a surgical video of ICL implantation. The most important step is loading the lens into the injector such that the correct side faces up, 2 side ports superiorly and inferiorly, a temporal main port. The chamber is formed with visco and the ICL is injected into the ciliary sulcus, allowed to symmetrically unfold. Visco is given to guide it along, and very gently the foot plates are positioned under the iris such that the optic is not damaged and the crystalline lens is not damaged, and a thorough irrigation is done for at least 2 minutes to remove the visco. Now in this is the Evo Vision ICL, and in this we can see a central 360 micron port. So this port is very important to ensure a physiological flow of aqueous and has been known to reduce the incident of cataract as well as post-op IOP rise. While smaller ports lead to inadequate drainage, larger ports can cause optical aberrations. So again, the importance of sizing cannot be overemphasized. Improper sizing is improper vaulting. Now a large vault will lead to chafing with pigment dispersion and angle closure, whereas a small vault will lead to cataract and ICL rotation. This is an anterior subcapsular cataract caused 18 months post-operatively. IOP rise post-op can be because of many reasons, but the most important reason is a pretrabecular block because of retained visco. The other mechanisms can be pupillary block because of an exaggerated lens vault and malignant glaucoma. The other symptoms are, the other complications are endothelial cell loss, IOL decentration and rotation, and nighttime symptoms like glare and halo. So the homework for the next class is multifocal phakic IOLs and bioptics. So thank you very much. I'll read up, ma'am. Ma'am, the multifocal IOLs are basically fake. The main disadvantage of phakic IOLs is the loss of accommodation. So if we can overcome this with the help of multifocal IOLs, then that would negate that particular. So right now the CARE group is developing multifocal IOLs from a dioptric range of 1.5 to 4 diopters of presbyopic correction. So these patients will, they'll basically be able to accommodate, and it will simulate a more natural quality of vision. They have not yet come into the market, but they are underway.
Content coverage. Time.
Yes, ma'am. Okay, ma'am.
Thank you.
Yes.
So we
Thank you.
Move on to the next. Dr. Veena Vishwam is here.
Yeah, that's what. Veena.
Presenter. Who is going to present? Dr. Veena is here. You are the mentor. Who is going to present? Please come over, presenters. Sri Lakshmi.
So we can go back to number 1, sir. Kasturi Bhattacharya.
Oh, yeah, no, to abhi. Done. She was done, I think, right now.
Oh, no.
Abhi.
Okay.
Two has been done.
Oh, yes, yes.
Both of them will present. Okay.
Yeah, no. Rutusha is still yet to do. Yeah, come. Rutusha is yet to do. Rutusha
Who was
Dorwad.
the first one?
Rutusha.
No, first one was
First
Reema,
one was
Dr. Reema.
Hitisha. Hitisha. Abhi.
Hitisha. She was Reema's student, no?
Yeah, she is at
Oh,
retinoblastoma. Who spoke on retinoblastoma? Hitisha. And Abha Gupta spoke on?
Good morning, students. Welcome to my class, and I am Dr. Ritusha Dodwad. Today we are going to talk about the management of macular hole. In our previous class, we've already brushed up a little on what is a macular hole and why is it caused. So now we are going to discuss about the management of macular hole. What is a macular hole? Would anybody like to attempt the question here? Any students? It's a small gap in the retina at the level of the macula, and this is an OCT imaging. The second picture that we see is a normal OCT image of the normal macula. We have seen and diagnosed the macular hole on an OCT. But what is the slit lamp examination which will help us to diagnose the full thickness macular hole? It's a good question, right? I want you to go back home and read up on this and tell me the answer tomorrow. This is a very nice diagram depicting exactly why a macular hole and how a macular hole is caused. First, there is vitreous condensation above the macula, there is vitreous traction, and there is centrifugal pull and centrifugal traction which leads to gaping of these retinal layers, leading to the loss of the retinal layers at the macula. Anyone would like to attempt the staging of macular hole? Any guesses of how it's graded? Okay, I'll help you there. Stage 1 is basically a yellow dot that we see at the macula, and on OCT it is the horizontal schisis of the retinal layers. In this case, we can always wait and watch. And we can also attempt another newer modality, which is the ochreplasmin injection. Ochreplasmin is a proteolytic enzyme. And how does it help us with the macular hole management if it's a proteolytic? Come on guys, be interactive. How does ochreplasmin help us? Yes, very good, excellent, smart kid. So anything beyond stage 2, which is a full thickness macular hole with or without a posterior vitreous detachment, we go ahead with the surgery. There are two main principles that we want to attempt with the surgery. First is to relieve all the tangential traction, that is either by removing the vitreous condensation, and second by the epiretinal membrane removal. And the second principle is to provide a retinal tamponade. We do it with the help of the gases, so that the anatomical apposition that we have attained with the surgery is maintained. Here we are attempting a 3-port pars plana vitrectomy, a 25 gauge. We are marking the port distance from the limbus at 4 millimeters in the phakic patient here. We do a core vitrectomy and stain the remnant vitreous with the help of triamcinolone acetonide. We see that around the disc there are white strands, and we are removing the posterior hyaloid attachment from posterior to the anterior and making the we are exposing the internal limiting membrane that we are supposed to stain next. How will we stain the internal limiting membrane? We use a brilliant blue dye here. Any other dyes we can use? Any other dyes we can use for staining the ILM? We use the ICG as well. So after staining the ILM, we can see that there is a blue color sheen. We are using a Finis loop to scrape off from where the vessels are there, because the ILM is least adherent at that point. After the flap is obtained, the initial flap, we take a forceps and do a maculorhexis. What is a maculorhexis? Just like a capsulorhexis. We do a tangential traction, a maculorhexis, and we go 360° around it. Usually a 1.5 to 2 diopters maculorhexis is done here. We do not, beware, we do not pull it perpendicularly but tangentially. After we've achieved the maculorhexis, we do a fluid gas exchange, where we are maintaining the environment around the macular hole in a dehydrated state, and the apposition that we have attained of the macular hole gaping, we will tamponade it with the help of a C3F8 or an SF6 gas at the non-expansile concentration. As every surgery, there are a few complications here as well. First is the nuclear sclerotic cataract, a later reopening of the macular hole, a peripheral retinal break, and a wedge-shaped temporal visual field defect, very rarely though. There are certain challenging cases in a macular hole surgery, which is basically the macular hole is chronic, non-healing, size greater than 300 microns, and in these cases we have the advancements. I want you all to read up on advancements and come back in my next class, and anybody who does the 3 main advancements will get a Cadbury from me. Up for the challenge, guys? Yes, great. Thank you so much.
Very interesting presentation.
Thank you, sir.
What 2 important post-op advice that you like to give in a post-macular hole surgery?
Sir, if we are instilling the gas, we would ask the patient to lie in prone position for around 5 to 7 days, and the advice of...
hours in 24 hours?
No, sir, usually around 12 hours, but not over the whole 24-hour period. As much as the patient can tolerate, around 6 to 12 hours, sir.
What's second most important advice?
Sir, anything that induces a Valsalva, or in basically any strenuous exercises, we'll ask the patient to avoid.
Your patient has come from Jammu and Kashmir.
Air travel, sir. Air travel we'll ask him to avoid if we are instilling gas.
It's very important that you have to strictly advise them not to travel where the gas is.
Yes, sir.
Is there any difference if you injected air or you injected long-acting gases in air travel advice?
Sir, I think it is over the period of time that we can allow the air travel. So if it is air, then so I'm not very sure about this, but I think the
What is the procedure to attend your class?
to attend, ma'am, it's free of cost.
So, Professor Rutusha,
Yes, sir.
probably you could have, Rutusha, yeah. Probably you could have mentioned something about the clinical aspects of examination
Of macular
of a macular hole. Like we have the Allen-Wadsky test,
Yes,
and
sir,
the
yes, sir.
laser beam test.
Yes, sir.
These you could have spent about 10-15 seconds on these before you started off with the OCT evaluation.
Yes. So that I wanted to give as a homework to the students because that is a very handy test that everybody can use.
I know
so I
4
wanted
minutes is too short to
Yes,
cover
sir.
everything, but I
Yes,
think
sir.
that's very important from the examination point of view.
Yes, sir, I agree.
Some examiners are still fond of asking these questions.
Yes, sir.
And ochriplasmin is not used
Used.
nowadays.
Yes, sir.
So I think we can avoid telling that to the students.
Okay, sir.
If any examiner asks what is the medical management of a macular hole stage 2, then we can probably mention about
Mention
ochriplasmin. Otherwise, it is not used in the
Used
present
these
age, discontinued because of its toxicity.
I'll keep that in mind, sir.
Who's your mentor?
So Dr. Kasturi Bhattacharji, ma'am. Thank you.
You got a beautiful mentor. Gargi has presented, no? Abha, come. Abha. Judges are all confused only. Okay. Huh? All girls, yeah.
Both teachers and students, all will be girls in ophthalmology.
See here also, no?
So we had both presented.
Yeah.
Introduce yourself. You are Abha.
This is Ritusha Gagi, all will be presented.
Good morning, everyone. So today we'll discuss a case of simple limbal epithelial transplant. Coming on to the basics first. It was first described by Sangwan et al. In 2012. Simple limbal epithelial transplant is a single-step surgical procedure to treat uniocular limbal stem cell deficiency, which is characterized by conjunctival epithelial ingrowth, persistent epithelial defect, chronic epithelial staining, and loss of transparency or integrity of the cornea. Coming on to the indications for slit, it is usually done in unilateral ocular chemical burns, contact lens induced limbal stem cell deficiency, and it is also used for ocular surface reconstruction in ocular surface cell neoplasia, primary or recurrent pterygium, post-topical mitomycin C use, and a laryngo-oncocutaneous syndrome. The contraindications mainly include diseases which have a bilateral involvement, like congenital limbal stem cell deficiency occurring in aniridia or xeroderma pigmentosum, autoimmune disorders like Stevens-Johnson syndrome or pemphigoid, any dry ocular surface with keratinization of cornea or conjunctiva with the Schirmer's less than 10 mm with anesthesia, any blind eye which does not have any visual potential, any disorganized anterior segment with extensive peripheral anterior synechiae or adherent glaucoma, any untreated adnexal pathology which includes lag of thalamus, dacryocystitis, trichiasis or entropion, as it will delay the corneal healing. Before coming on to the surgical steps, it is important that we know what patient preparation we need. It is important that we have a detailed history of the patient with detailed slit lamp examination. And if we have the technology, we should always go in for an anterior segment OCT to look in for the corneal thickness. The surgical steps are 3 steps. In the first, the donor site preparation, we have to do a 2 into 2 mm marking across the superior limbus. Now, why the superior limbus? Because it has the maximum amount of limbal stem cells in palisades of Vaux, and it is also covered by the superior eyelid. Then there is a subconjunctival dissection, which is carried out 1 mm into the clear cornea, and the limbal tissue is excised and kept safely in a balanced salt solution. In the host site preparation, 360-degree peritomy is done and any fibrotic tissue is removed, but we leave the healthy corneal epithelium and the bare ocular surface is covered with human amniotic membrane. Now, why human amniotic membrane is because it acts as scaffold for growth and is anti-angiogenic, anti-fibrotic and anti-inflammatory. For the graft placement, we cut the donor limbal tissue into 8 to 10 pieces and the graft is secured on the overlying amniotic membrane with fibrin glue and a soft bandage contact lens is placed. Coming on to the post-operative care, the patient should always be started on preservative-free topical antibiotics and topical prednisolone phosphate 1%. The bandage contact lens can be kept up to 1 to 2 weeks depending on the healing of the patient, and the topical steroid should always be tapered after the removal of the bandage contact lens, and we are supposed to give a good amount of carboxymethylcellulose 0.5% eye drops. Coming on to the complications, it can be divided into recipient eye and donor eye complication. In the recipient eye, it can lead to hemorrhage under the amniotic membrane, any detachment of the amniotic membrane that can occur, early loss of stem cell transplant, sterile or infectious keratitis, any recurrence of conjunctivalization, symblepharon, and in the donor eye, it can lead to focal or non-progressive limbal stem cell deficiency, pyogenic granuloma, or even a subconjunctival hemorrhage. So the take-home message for this class is that the simple limbal epithelial transplant is a one-step procedure which does not require any surgical setup and is cost-effective. And also, since it is an autologous transplant, there is no need for immunosuppression. But we should keep in mind that the major indication to take up the patient for SLET is that it should be done in uniocular disease pathology with a healthy contralateral eye. Thank you. And I would like to thank AIOS and my professor, Professor Reema Bansal, for guiding me through this class.
How the teaching could have been better? Or
yeah. Can you tell me anything about the indications based on the, can you classify the limbal stem cell deficiency and which one which will be suited?
It can be congenital or acquired. In congenital, it can be like, it is usually bilateral, so we avoid SLET, which includes PAX6 mutation, in which there is severe limbal stem cell deficiency in aniridia or xeroderma pigmentosum. In acquired, it can be bilateral or unilateral. Unilateral, in cases like the most common indication for which we do SLET is the ocular burns, chemical burns, in which we present because it is unilateral and we can go forward with it. And also in cases like there is primary or recurrent pterygium, there are instances that there is localized limbal stem cell deficiency, so we can go forward with it. However, in systemic cases like Stevens-Johnson syndrome or any other autoimmune disorder, it is important that we thoroughly look at the contralateral eye. It might be unilateral in presentation where we can go forward with the SLET, but usually it is bilateral, so we try and avoid it in systemic cases of limbal stem cell deficiency.
What's the biggest hindrance to SLET in clinical practice when you're counseling the patient?
Ma'am, the biggest threat is that we are actually taking a biopsy of the healthy eye of the patient. So it is important that we counsel the patient that yes, we will be taking a biopsy of the healthy eye, which is usually taxing. Yes, consent. Yes, ma'am.
Often you do not get consent for SLET.
Yes, ma'am.
Just a suggestion, you could have added more pictures in the first introductory slides, because for students to understand later the surgery and all those procedures, you very well demonstrated it quite well. But in the initial where you're showing the indications that you could have added. So the visual impact is much better for the students.
I will keep this in mind, ma'am.
Yeah, thank you.
We call now Dr. Kalpit Shah. Thank you. Dr. Kalpit Shah, who is the mentor for
morning class. So what is common for all these people on screen? Well, they have been hit by something with mass and acceleration on the eye, causing sudden deceleration, causing huge amount of force to be transferred on the eye and adnexa. This leads to huge amount of damage. This brings us to the topic of today's discussion, closed lobe injuries. I'm Dr. Pavan Garde, mentored by Dr. Kalpit Shah. What are closed lobe injuries? They are basically blunt trauma which causes injury without causing scleral rupture. What are the various settings in which it can occur? It can occur in sports injuries, it can occur during assaults, or it can occur during accidents. They are more commonly seen in males. What are the different mechanisms that can happen in closed lobe injuries? Basically, first is the Coop mechanism, where there is a direct force impact on the structure. Counter Coop mechanism, in which there is pressure wave is transferred to the posterior pole, and ocular compression, in which there is sudden anterior posterior compression of the eye, causing lateral expansion, causing damage to the equatorial structures. Coming to examination, how do the patients present to you? The patient basically comes to you with a history of trauma, with followed by pain and which may be associated with sudden diminution of vision. So you take a detailed history. Always take a non-EPR consent, or if it's a EPR case, inform the police. Remember, कोई भी risk नहीं लेने का. Then when you come to the examination, first things first, take vision. Vision, if the range can be from 6.6 to no PL, no matter what the vision is, you have to first do a slit lamp examination. Then you have to do the IOP measurement. If IOP measurement is normal, always dilate the patient and see the fundus. These three examinations are always mandatory for any blunt trauma injury. So what are the different things you can see in slit lamp examination? First, you can see conjunctival tears. If they are small enough, they can be managed conservatively. If they are large, they can be sutured. There can be conjunctival chemosis with subconjunctival hemorrhage. They may look scary, but can be managed conservatively. Then in cornea, you can have descemet membrane tears due to inelasticity of descemet membrane. Also, endothelial damage can cause corneal haze. Coming to anterior chamber, there can be hyphema. These are the various gradings of hyphema. These are very important Viva question. Please take a note. Hyphema can be if there is no subconjunctival hemorrhage around associated with it, it can be managed conservatively. If there is conjunctival chemosis and subconjunctival hemorrhage, always explore to look for any scleral ruptures. Hyphema can be left. You need constant vigilance when there is hyphema, because during 4 to 7 days there can be always a rebleed. Then post-trauma patient, when they come in follow-up, always look at the angle structures, because there can be angle recession which can be seen as irregular widening of the ciliary body band, or there can be also be ciliary cyclodialysis in which the patient can present with ocular hypotomy. Then trauma to lens can cause traumatic cataract, which is rosette-shaped cataracts. Then there can be zonular dialysis, in which there will be lens subluxation. There can be IOL bag complex complications, in which there is IOL bag can be subluxated or can be into the vitreous cavity. Then there can be vitreous hemorrhage. Note on Terson syndrome, which is vitreous hemorrhage associated with subarachnoid hemorrhage. There can be retinal dialysis, retinal tears. Berlin's edema can be present. Traumatic macular holes are present. There is choroidal rupture, which requires observation only. Traumatic nerve avulsion is the most severe complication. Orbital fracture can also be present, which can have muscle entrapment. These are the various references, and thank you. Prevention is the main key, and these are the various resources that you can go. You can scan the QR code and you will get a Dropbox links to that.
So, Pawan, I think you should start off in a trauma lecture like this to the students. You should start off by saying any trauma should not be trivialized. However trivial it might appear, you should have a keen sense, index of suspicion for sight-threatening and life-threatening situation underlying. So this is one thing that you should start off with. So it may be just a black eye, but he might have sustained a head injury which will manifest 24 hours later, and he might end up in the ICU with a subdural hemorrhage. So this is something that you should start off with, and then you can go on to the rest of the examination. So please don't forget that.
Is radiological examination mandatory?
Yes, sir. In case if you are not able to, radiological examination can be local as well as.
Can be local. Patient comes with blood trauma.
Yes, sir.
Will you advise radiological investigation?
Yes, sir. Because blunt trauma, you can have head injury, and NCCT brain is mandatory. He can have a bleed which can progress to which he can have complications later.
I'm asking X-rays. Will you advise any X-ray in these patients?
Yes, sir.
And what do you look for?
Intraocular foreign body, and orbital fractures.
So you have done blunt trauma.
Blunt trauma.
What about posterior scleral ruptures? You should have told the students how to identify it from a pure conjunctival hemorrhage, which is extending towards the temporal or nasal periphery. How to differentiate it from a posterior scleral rupture clinically. The eye would be soft,
Yeah, okay.
and the extent, it goes further beyond, Whereas a clinical signs which the student has to pick up when he's examining a patient?
The deep AC, the hyphema, the peaking of the pupil, the soft eye, all point towards an occult rupture. Could be posterior, which you cannot see. These are things. And you should also mention about the timeline of your examination, like what you will examine on day 1 and what you will examine, what will be the follow-up regimen, and what you will examine at each follow-up visit. These are things which are important from the practical point of view of management of the patient.
Actually, it was there, but it was not fitting in the.
Yeah.
So actually,
Also,
the
what you
detail.
should avoid, no digital pressures and all that you have to also mention. Small key points which are important for a student to know.
Thank you, sir.
Okay, Namaskaram Kochi. So today I will be talking to you about two distinct and novel techniques of endothelial keratoplasty named Descemet membrane endothelial keratoplasty and pre-Descemet endothelial keratoplasty. So I'll start the class off with a short story about this. So there was this ophthalmologist in Nottingham who while performing lamellar dissection noted that there was a distinct strand which was present between the stroma and endothelium which he thought might be Descemet membrane. But while performing the descemetodexis the same strands were absent. So then they got curious and performed imaging and histopathological analysis, and they found that there sits a very distinct layer between stroma and Descemet membrane, which we now know eponymously as the Duas layer. So what that gives you students is another short note to study about, but what that gives to surgeons is a perfect plane of separation between stroma and Descemet membrane, and what that gives us is a way to find thinner grafts. So in Descemet membrane endothelial keratoplasty, the grafts comprises of Descemet and endothelium, whereas in pre-Descemet endothelial keratoplasty, the grafts comprises of pre-Descemet, Descemet and endothelium. So now you might ask that why do we need these thinner grafts? We already had ultra-thin DSEC, we already perfected that graft. But what was the problem with that? Was there was a tenacious thin layer of stroma that we could not get rid of. And why do we need to get rid of the stroma? Can anybody answer that? Why do we need to get rid of the stroma? Is because with thinner grafts, what we can have is better visual acuity, faster rate of improvement, and less chances of graft rejection. So what is importance of this thinner graft? Who will be benefited from this? So the indication of performing this endothelial keratoplasty is in patients who have to have optical corrections, like patients with ABK and PBK, pseudophakic aphakic bullous keratopathy, patients with Fuchs endothelial dystrophy, any other congenital and hereditary endothelial dystrophies, and patients with eye syndromes. So now, who will tell me how to perform this endothelial keratoplasties? Can anybody tell me? Okay. So it is easy to identify it histopathologically, but it is difficult to find it clinically. So what they did was they tried to perform pneumatic separation. They injected air into the cornea by endothelial, putting the donor graft endothelial side up. And when they injected the air with a 30G needle, they found that one type of bubble which formed from center to periphery, which was around 7 to 8 mm in size, and it was very well distinct compared to another bubble which formed from periphery to center, which was larger than the first bubble, and also it was very less distinct bubble. So if you perform the comparison, the first big bubble forms between stroma and pre-Descemet, whereas the another big bubble that forms between pre-Descemet and Descemet. So they named it type 1 big bubble, which now gives us the pre-Descemet endothelial keratoplasty graft, whereas the type 2 big bubble gives us the DMEC graft. So for preparation of the recipient, what we do is make a partial thickness definition depending on the size of the big bubble and also the indication of the keratoplasty. After performing that, the area that we delimited, up to that area we perform descemetodexis and remove the diseased endothelium and Descemet membrane. After that, the graft is placed, whatever graft we already prepared by the big bubble technique, we inject it with the clear corneal incision into the eye with a single-use injector. And after that, we place the graft in the position with manual cannula and also putting the air bubble into anterior chamber. So this is the comparison between the two techniques. I already mentioned everything, the size and the characteristic. The only thing that I have to mention is the donor age and the type of procedure. So DMEC is a type of procedure which is tissue neutral. So whatever we are removing, we are only putting those tissues, Descemet and endothelium. Whereas PDEK is minimally tissue additive because we are putting another layer which is pre-Descemet layer. And another thing is the donor age. So in DMEC, the donor age is dependent. So we only prefer the grafts which are more than 40 years. And one of you has to find out the reason why do we do that, okay? And PD is independent. In PDK, what happens is we can use any type of graft, which any age. So it increases the donor pool virtually to very much. Okay, so this is the advantage of DSEC over PDK and DMAC, which is technically easy and minimal tissue loss in easy graft unrolling, whereas DMAC and PDK, they do not require any special instruments, there is no induced hyperopia, and there is partial visual recovery. I'd like to thank my mentors and okay, thank you so much.
That was a good presentation, and over to the experts, the corneal experts.
So you said that it's donor age dependent, and you asked the class to find out the answer. Will you give the answer? Why?
So basically what happens in DMAC is that if we only have the endothelium and the descemet membrane. So when we try to unroll the graft in the cornea, it is very difficult for the young cornea, young grafts to unroll because the endothelium and descemet membrane are sticky. But what the pre-descemet layer provides us is a stability. So the graft is...
I'm not talking about PDAC, just on DMAC. Why is it donor age dependent?
Because it is very difficult to unroll the...
Before that, peeling, preparing the graft, any issues?
Because endothelial cell loss which occurs because of...
Okay, do read up.
Dr. Sri Lakshmi Prasad.
Thank you all.
Thank you.
Good morning, students. Today, I want you to meet this amazing lady, Leah, who walked into our OPD some times back. Her problem was, in this cosmetically oriented world, her husband thinks she may scare their kids, and she needs our help. So, let's see how we can help Leah. As ophthalmologists, our area of interest is her eyes. So, let's have a closer look of her eyes. At this point, I hope you all remember our last class about the contracted socket. So, what do you see here? Yes, there is shortening of the lower fornix. So, according to the Gopal Krishna classification system we have studied in the last class, this is grade 1 contracted socket or a mild contracted socket. Okay, so let's have a quick recap. In grade 2, there is shortening of both upper and the lower fornix. Grade 3, there is shortening of all the four fornixes. And grade 4, there is shortening of all the four fornixes with vertical and horizontal narrowing of the palpebral fissure. And grade 5 is a recurrent contracted socket post-reconstruction. So for the treatment of a contracted socket, our primary aim is to create a socket so as to maintain a prosthesis with good cosmetic appearance. So before socket reconstruction, we have to do a proper socket evaluation and take all the necessary precautions, then take a written informed consent from the patient and explain the prognosis to the patient very well. So in case of a grade 1 contracted socket with adequate fornix, then we have to just modify the prosthesis. In case of inadequate fornix, there can be shallowing of the fornix with or without fat prolapse. If there is shallowing of the fornix with fat prolapse, then we can do an open method of repair. And if there is only shallowing of fornix, like as in case of Leah, then we can do a closed method of repair. So, there we put fornix forming sutures for deepening the fornices. Then in case of moderate or a severe contracted socket, then we have to see if it is a moist socket or a dry socket. In case of a moist socket, then we do a mucous membrane graft, that is the gold standard. Here full thickness graft is preferred because it is less prone to contracture, and we can also go for a hard pellet graft or an amniotic membrane graft. In case of a split thickness dry socket, we can use a split thickness graft which is taken from the inner aspect of the thigh with a dermatome, and that is tied onto the socket. And if there is conjunctival and the volume deficit, then we go for a dermis fat graft. Okay, then here in recalcitrant cases, exenteration of the eyelid and the residual socket material is done to create a cavity into which the prosthesis can be fitted. So after this, when the socket is reconstructed and it is healed, then we can place a custom made eye prosthesis in that. So if nothing is possible, then there are optical methods to improve the appearance. You might think that this is a cutout piece of the eye, but no. Here, this is a prosthesis which can be mounted to a spectacle and see the excellent result obtained in this patient. So at this point, you might be very curious how our Leah look after reconstruction. So here she is smiling with her beautiful eyes. So that's all for today's class. So before winding up the class, here is a video for my Pirates of Caribbean fans. So if you find Reggie somewhere, you just go and tell him that we have so many options for him. So that's all for today's class. And okay, one more thing, you have an assignment. Complete this and bring it in the next class. I'll share this slide in a WhatsApp group. Okay. So see you in the next class. Okay, bye.
Okay, teacher, we'll see you in the next class.
Yeah. Okay then. Thank you.
Any comments from any of the judges?
Any oculoplasty people here who can...
Any doubts, students?
Who can judge on our behalf?
Yes.
Our teaching skills. Actually, she did very well.
Thank you, ma'am. Thank you.
Next is
Lakshmi, please come up. Please go.
Lakshmi.
Lakshmi Kumar.
Are you lazy or are your eyes? Good morning all. Today I'm going to teach you the recent advances in the management of amblyopia. In amblyopia, is the eyes which are lazy? No, it is a lazy brain rather than lazy eye. When you think about the treatment of amblyopia, the first thing that comes to our mind is patching. But patching, like all other classical treatment, aims to improve the visual acuity of the amblyopic eye alone. The current concept is that amblyopia is a binocular disease rather than a uniocular disease. Then came the newer therapies like binocular therapy and perceptual learning, which aims to increase the binocular single vision in addition to the visual acuity. Now, what is this binocular therapy? Binocular therapy includes all the therapies in which both the eyes are used together. It includes dichoptic training. In dichoptic training, independent and visually different stimulus are given to each eye separately using anaglyph glass. This is the anaglyph glass. Here, high contrast image is given to the amblyopic eye and low contrast to the sound eye. And the patient can use both these images to view a full view of the image. This is the principle involved in all the dichoptic training methods, which includes the Digrash game, falling block game, dichoptic movies, virtual reality display, mobile apps and games, and interactive binocular therapy. Now let's see the Digrash game. Here, the gamer has to collect a goal in the card and a star point is earned. As the game progresses, the contrast of the sound eye is increased. But with unsuccessful 30 minutes of gameplay, the contrast is reduced. Same is with the falling block game also. Here, the blocks will be falling from top to bottom and the patient has to make a line with the help of these blocks. Next is Orthoptech. It's a magnocellular pathway stimulator invented by our Indian doctor, Dr. Sandan Gopal. Here, 3 rows of white light will be seeing, the center one being the red. The patient has to point with his laser to the light he is seeing. Same with the Occlupad or Occlutab, but done with an iPad and polarized glass. It has been said that children has got better adherence with this type of gaming. So visual acuity improvement is much more when compared with patching. Can you identify this legend? Yes, it's our legend Lionel Messi practicing and scoring. Practice makes a man perfect. This is what the perceptual learning is. Simple tasks are given to the patient and he is asked to repeat it again and again. The stimulus given are the Geber's patch, vernier acuity, and the letter optotypes. But the studies shows that there is not much improvement when compared with patching. But the advantage is that it shows some promising result with adult amblyopia therapy. Numerous trials are going on and let's hope that in future it may become the gold standard of treatment. Till then, the gold standard is our own patching. The cost of binocular therapy is also very high. So the question is it affordable to everyone? Now let's see what's new with the occlusion therapy. You have the liquid crystal glasses which changes from transparent to opaque. occlusion dose monitor from which we can know the adherence to patching, and same is with Theramon, the temperature sensitive microsensor. Now we have the drug therapies, which includes levodopa, carbidopa, citicoline, citalopram and donepezil. Trials are also going on with this. So the take-home message is that it is a lazy brain rather than lazy eye. Amblyopia is a binocular condition rather than a uniocular condition, and our goal should be to improve the binocular single vision in addition to the visual acuity improvement. Hope all of you understand my class. Let's wind up then. Any doubts? See you all in the next class.
Shri Lakshmi, that was a good presentation. But don't forget the old when you're speaking about the new. You didn't mention about penalization.
Yes, ma'am.
Would you suggest penalization to anybody, or you would prefer all the newer techniques only?
First we will try to correct the basic refractive error. Then after that we can try patching or penalization. When it is not compliant with the patching therapy, whether any allergic to the patching, then we can go for penalization. Yes.
I'll pose you with a problem, okay? There is a child who is constantly on his tab, mobile, and doesn't listen to the parents. And this child, you want to give him some form of amblyopia exercises with video games.
Yes.
Okay. How will you go about it?
We can first basically we can correct the refractive error. Then after that we can give the child interesting dichoptic games. That near vision activities will help to improve the amblyopia.
See, the problem is not that. The problem is the number of hours of usage.
1 hour or 2 hours can be given each day.
As I told you before, he's constantly on his mobile, on his laptop. Okay? Chance of myopia increases.
Yes, chance of myopia increases.
Also the chance of digital eye strain, dry eyes, which starts many a times in children only nowadays. So how will you manage that? Will you give something or some alternative to this?
We can give this binocular therapy.
Thank you.
We must congratulate the mentor. I think your students are going to give you run for your money. Good presentation.
Thank you. Thank you.
Next is Dr. R. Sai Sunanda. Set of two students, Dr. Aishwarya Bhakta later, or Dr. Sai Sunanda.
Good morning, class. Today we'll be studying about endonasal dacryocysto-rhinostomy. Okay, it means we're creating an opening between the lacrimal sac and the nasal cavity through the nasal approach. This was introduced by Caldwell back in 1893. However, the modern technique with the help of endoscopes was reported by McDonough and Mering in 1989. In whom do we do this surgery? In patients with nasolacrimal duct obstruction, be it congenital or acquired. Unlike external DCR, we can do this in case of acute dacryocystitis as well as lacrimal abscess. Okay. Obviously, we should know in whom we should not go for it. In patients with blood dyscrasias, lacrimal sac tumors, lacrimal sac rhinosporiosis, and common canalicular stenosis. However, in patients with history of midfacial trauma, lacrimal sac diverticulum, and obstructive nasal pathologies like Pollock are relative contraindication to it. Yeah, before going into any surgery, obviously we should know about anatomy. Let's see it. The lacrimal sac is located superiorly, anteriorly, and lateral to the middle turbinate. It extends about 10 mm above the axil of the middle turbinate and 4 mm below it. So our operative field is going to be in the middle meatus. Now coming to the maxillary line. It extends from the axil of the middle turbinate to the inferior turbinate. It corresponds to the social line between the thick bone maxilla and the thin bone lacrimal bone. So our aim is to create an easy bony ostium by exposing the thin bone. Now let's go into the surgery proper. It can be done under general as well as local anesthesia. However, general is more followed as we can control the intraoperative bleed. And patient is made to lie in reverse Trendelenburg position, and surgeon always positions himself on the right side. Now, with the help of an endoscope, we'll examine the cavity and we'll decongest it with the help of xylometazoline. Now, the lateral nasal wall, anterior and superior to the middle turbinate, is infiltrated with the help of 2% xylocaine and 1:80,000 adrenaline. Now, using a 15 number blade, a vertical incision is made 10 mm anterior to the maxillary line, and it is joined superiorly and inferiorly to the maxillary line. Now, using the Freer's elevator, we are elevating the mucoperiosteal flap until the lacrimal bone is exposed. Now, using the Kerison's bone punch, we are doing the osteotomy. Now, first initially we are engaging the anterior lacrimal cusp and we are removing the bone until the entire lacrimal sac is exposed. And how will we confirm that this is the sac that is being exposed? With the help of probing. And this also tells us that we did the sufficient amount of osteotomy. Now, with the help of keratome or sickle knife, the lacrimal sac is incised vertically, okay, until the contents are drained out. And here you can see the pus coming out through the sac. And releasing cuts can be made with the help of Westcott scissors. Now, using a ball probe, the nasal mucosal flap and the posterior lacrimal sac flap are opposed edge to edge. This is to promote primary intention healing. Now, this can be achieved even without an endoscope, the non-endoscopic technique. But we'll be needing a 23 gauge vitrectomy light pipe, which is sent through the lower punctum into the lacrimal sac, and the transillumination is observed. Adjuvants like lacrimal stunting and antifibrotic agents like mitomycin C are in practice to decrease the chance of failure. So, silicone tube prolapse, medial rectus injury, nasal mucosal adhesions are some of the complications you can come across. So, now that you know about it, to brush your memory, you can go through this. Thank you. Any queries? Why not external DCR? Yes, external DCR in this world. Okay. Lacrimal sac is also our department. No? We can go for endonasal thing. Yes, the one thing is, in this world, many people prefer not to have a scar. We can go for a scarless surgery if it is an endonasal procedure. And the other thing is, in case of acute dacryocystitis and lacrimal abscess, if you go for an external DCR, it will leave you a fistula formation. The chance of forming a fistula and contracted scar is more when compared to endonasal one. Yes. However, the gold standard seems to be external DCR, but recent studies show that it's on par with external DCR. Thank you.
So many Aishwaryas.
Hello. Start. Okay, so good morning class. Today we are going to discuss about posterior vitreous detachment or PVD. So what is vitreous? Vitreous is a gel-like substance present between the retina and the lens. Separation of the cortical vitreous from the ILM layer of the retina is known as the posterior vitreous detachment. Before knowing about PVD, we should know about the normal attachment of the vitreous. The strongest one being at the level of ora serrata, followed by optic disc margin, then the fovea, major blood vessel. The other sites of attachment are lattice degeneration, chorioretinal scars, etc. With age, there is liquefaction of the vitreous gel and condensation known as synchisis and syneresis. This leads to collapse of the vitreous and weakening of the vitreoretinal adhesion, resulting in PVD. PVD is a physiologic event directly related to age. The other risk factor associated with PVD are previous cataract surgery, PCR, yak capsulotomy, trauma, inflammatory condition like uveitis, myopia, syndromes like Stickler syndrome, retinitis pigmentosa, retinal laser, cryo, etc. Patients with PVD presents to us with symptoms like mobile, small, cobweb floaters, occasional flashes, or sometimes blurring of vision. On examination, we often find a Weiss ring, which is a glial tissue, indicates separation of the vitreous from the optic disc margin. We also need to look for any associated complication like vitreous hemorrhage, retinal tear or retinal detachment, vitreomacular traction, macular pucker, vitreopapillary traction, etc. B-scan is an important diagnostic tool which helps us differentiate PVD from retinal detachment, where PVD is a thin, smooth membrane, may or may not be attached to optic disc margin, shows good after movement, whereas RD is a thick folded membrane, always attached to optic disc margin, shows limited after movement. On A-scan, PVD shows less than 100% of spikes, but RD always shows 100% of spikes. OCT is an important diagnostic tool to stage the PVD. Stage 0 indicates no PVD. Stage 1 and 2 indicates perifoveal PVD with vitreous attached to fovea as well as the optic disc, where stage 3 indicates the vitreous is separated from the fovea, but it is still attached to optic disc. Stage 4 indicates complete PVD, where vitreous is separated from the optic disc as well. Mainstay of management is reassurance. We need to assure the patient that the symptoms will resolve on its own. We keep them in follow-up, in 6 months or 12 months of follow-up. We need to explain about the warning signs like increase in number of floaters, increase in frequency of flashes, decrease in vision or visual field defect to visit to an ophthalmologist. If the floaters are affecting quality of life, we can go for pars plana vitrectomy or drug-assisted vitreolysis or Nd:YAG laser vitreolysis. If any associated complications are present, then we can intervene medically or surgically. Now we have seen the bad part of PVD. Let us see the good part of it too. Complete PVD prevents neovascularization. Surgical induction of PVD helps in managing refractile diabetic macular edema and relieving the vitreoretinal traction. These are the references. I want you to go back home and read up on this for further information. Thank you. Any doubts?
You're Aishwarya Bakri.
Yes, ma'am.
And who's your mentor? You're the mentor.
Was there any picture depicting the sites, common sites of firm adhesion of the vitreous to the retina?
Yes.
There was a picture. Okay, leave it.
Yes, the strongest one at the level of ora serrata, followed by optic disc margin. Then there is attachment to fovea and the major blood vessel. The pathological sites of attachment are the lattice degeneration, retinal tufts, cystic retinal tufts or zonular tractional tufts, chorioretinal scars. These are the pathological sites of firm adhesion.
You could have mentioned about the need for PVD induction during a surgical procedure in certain situations. In most situations.
Yes, sir. I mentioned about the benefit of it to relieve the diabetic macular edema retraction. Yes. There will be Weiss ring usually because the PVD starts perifoveally and then it gets detached from the arcuate vessels, then from the fovea and last to the from the optic disc margin. So we assume that if there is no attachment to the optic disc margin, then it is the post-equatorial attachments are lost. So it indicates usually complete PVD.
And one more thing you could have mentioned was the B-scan finding of a blood-layered PVD versus an RD.
I mentioned, sir.
Blood-layered PVD, which can be looking just like an RD, which not have much movement. So that is one thing which could have been mentioned. That's okay. I mean, in 4 minutes, you have done your best. Good.
Thank you, sir.
Thank you very much.
Next will be Dr. Ayushi Gupta, followed by Dr. Sakshi Jain, both mentees of Dr. Rakesh Porwal.
Good morning, students. So today we'll discuss about the recent advances in the management of myopia. Now, we all know what myopia is, right? It is the nearsightedness in which the parallel rays of light coming from infinity are focused in front of the retina. But why are we concerned so much about myopia? Because it is not just a cosmetic problem. It can lead to irreversible vision loss in the long run. Now, as you all can see the figures on the screen, myopia epidemic has become a major worldwide problem. And it has been estimated that by 2050, nearly 50% of the world's population would be myopic. And we all know that the COVID-19 pandemic has really added to this. So we need to control as well as prevent myopia. Now students, what are the myopia control strategies we know? We have the optical, the pharmacological and the surgical measures. Now the main cause of concern is the hyperopic defocus. And what is the solution to this problem? It is the myopic defocus. Now, what are the optical measures? The optical measures include the spectacles, the contact lenses and the orthokeratology. As the topic is the recent advances, so we will discuss only about the recent advances in spectacles. It can be the LenSet or diffusion, and all these type of new lenses that you can see on your screen uses the LenSet technology, and the one which uses the diffusion optic technology, it is the side glass vision. Now, I would like to ask you all, are you all comfortable with your glasses? I think many of us are not, but it is okay. Not everyone likes wearing glasses. But then, what is the other option that we have? Yes, we have the contact lenses. They provide you better cosmesis as well as good image quality. And one such lens is the MeSight lenses, which are FDA approved, specifically designed daily disposable lenses for myopia control. Now think, what if our problem gets solved while we are sleeping and we have to do absolutely nothing about it? So here is orthokeratology, in which hard contact lenses are worn during the night time and they provide you temporary myopia control during the daytime. But all these optical measures are not affordable by all. So one of the most effective intervention was that of atropine. Multiple studies, namely the ATOM 1, ATOM 2 and the LAMP studies have been performed, and very recently in India, the iATOM study by Dr. Rohit Saxena et al. Has showed higher efficacy of 0.1% atropine in the Indian cohort. Now in what age group can you use atropine? You can use it in young children, usually 6 to 12 years of age group, and with a myopia of 1 to 6 diopters. But what is more important is the documented myopia progression of at least 0.5 diopters in the preceding year. We all know the lifestyle of today's generation. Decreased outdoor activity, increased near work has really added a lot to the myopia progression. Now, what is the screen time recommendation? Screen time recommendation according to various age groups have been recommended, and in school going children, it is less than 2 hours per day. Increased lifestyle modifications such as increased outdoor activity but only 2 hours per day and following various rules for limiting your screen time can help you prevent myopia progression. Now, I would like to ask you all, it is the total time spent outdoors or the physical activity? What according to you is more important? Well, according to the Sydney myopia study, it is the total time spent outdoors which is more important. We have read everything about the control and management, but how would you apply it according to age? So spectacles can be prescribed in all age group, contact lenses in young adults, and atropine in young children. But once myopia has come to a halt, adults need myopia management too. And the invention of femtosecond laser has really changed the scenario. So everyone, students, keep your eyes on myopia, and this is the theme for this year's Global Myopia Awareness Week. Thank you.
Ayushi, thank you so much. That was a nice paper. You did not mention about the MyKiddo spectacles, which are there recently now with the central aperture and which helps to reduce the peripheral defocus.
Ma'am, yes, ma'am.
Okay. Thank you. Sakshi Jain. Yeah, looks like uniform.
Good morning, dear students. I am Dr. Sakshi from Team Rajasthan, Today we are going to discuss about one of difficult topic of ophthalmology, that is exudative retinal detachment and its management. There are ample of literature there, but I am here to make it simplify for this you. Now tell me, what is retinal detachment? It is fluid in potential subretinal space between RP and photoreceptor. According to etiology, it is of three types. If any break is present, it is rhegmatogenous. If any traction is present, it is tractional RD. And last but not the least, it is exudative retinal detachment, which is our main topic of concern. Exudative RD is collection of fluid in potential subretinal space due to breakdown of blood-retinal barrier, usually without any break and traction. These are the clinical features which all you are aware. Now, how would you approach it? For diagnosis of ERD, we need to ask about detailed history of the patient and ophthalmic examination. Ophthalmic examination, which I usually prefer, are slit-lag examination, detailed fundus examination, ultrasonography, OCT. And fundus examination is the main tool for examining any retinal pathology. Now, history is done, ophthalmic examination is done. What is our next step? Our next step is to determine the type of RD, to differentiate it from other. ERD is characterized by SRF can be clear or turbid, smooth elevated retina, vitreous is clear or otherwise, and hallmark feature of ERD is volume and gravity dependence. We need to differentiate it from tractional RD, where concave border of retina is present, and from rhegmatogenous RD, where pigments are present in vitreous. Now, let's play Pictionary and know more about ERD with the help of case-based scenario. In first case, there is a picture which is showing disc edema and SRF over macula and SRF at supratemporal to the disc. We confirmed it with OCT, which is showing serous retinal detachment involving fovea. Now tell me, what is this? I think you need more information. Like patient is having multisystemic granulomatous disease, IOP is raised due to uveitis, visual acuity is decreased, KP and posterior cynic in slit lamp. Now we can conclude it is VKH. In other case, there is a fundus photo of a patient of type A personality which is showing NSD. We confirmed it by OCT, and in FFA there is a smokestack pattern. What is this? Yes, it is CSCR. In case 3, there is a patient of tuberculosis with history of malaise and fever. In fundus photography, we saw exudative RD and choroidal granuloma. We confirmed it with OCT and B scan, and there is a reduction in size after ATT. Now we can conclude it is granular ERD with tuberculosis. In other case, patient with decreased vision and retinal detached ERD with choroidal mass and history of lip squamous cell carcinoma. We confirmed it with B scan. There is a hyperechoic solid choroidal mass. In CT, chest and brain, there is a lung and brain metastasis. Now all these are suggestive of ERD with choroidal metastasis. Now, how would you treat this? Thumb rule is it is generally treated medically, unlike RRD and DRD. In medical management, our focus is on underlying causes, and in medical management, we give immunosuppressive like IV steroid, intravitreal triamcinolone, and other steroids like cyclosporine, azathioprine, and methotrexate. Other interventions are cryotherapy, focal laser photocoagulation, and pars plana vitrectomy. Better than 1,000 days of diligent study is one day with great teachers. Thanks to my all teacher, and I hope you would never miss a case of ERD in future. Thank you. Thank you, sir.
Thank you, Sakshi.
How's the energy levels in the morning? I hope it's high, because today we'll be talking about one of the most interesting topics in ophthalmology, that is gene therapy. So let us start by defining what is gene therapy. It is basically the insertion of a gene into an individual's cells and tissues. Why? To treat a disease, particularly a hereditary disease in which a deleterious mutant allele is being replaced with a functional one. So before we move any further, we have to talk about the types of inheritance. We have autosomal recessive and we have autosomal dominant disease. In case of autosomal recessive disease, basically we have one gene which is being affected. Ma'am, the slides are like not working properly. Can I just reset? It's not working properly though. It's not changing. Change me. मैं लैपटॉप में कर देंगे. Can you restart the time? Okay. Good morning, students. How's the energy levels in the morning? I hope it's high because today we'll be talking about one of the most interesting topics in ophthalmology, that is gene therapy in ophthalmology. So let us start by defining what is gene therapy. It is basically the insertion of a gene into an individual's cells and tissues. Why? To treat a disease, particularly a hereditary disease in which a deleterious mutant allele is being replaced by a functional one. Before we move any further, we have to talk about the types of inheritance. Normally, we have two genes which produce two normal proteins. Suppose one gene is affected. At this point, one protein is produced, but the patient will be completely normal. Why? Because he's having another functional protein. Suppose, in case of a recessive disease, both the genes are affected. Both the proteins are being affected. At this point, the patient will start showing symptoms. Here comes the role of gene therapy, where we put a new gene, a new protein, and the patient becomes completely normal. Mind you guys, in case of an autosomal dominant disease, we have a defective gene producing a defective protein. At this point, what happens? The defective protein will even convert the normal protein defective. And even if we give a gene therapy, that particular protein will also be affected, making everything completely defective. So what should we do over here? We have something called as the gene editing via CRISPR technology, where the defective protein is being destroyed, the defective gene is being destroyed, and as a result, the patient becomes completely normal. Now you guys will be like, sir, we have known something about the gene, but how to put this gene into the human beings? Via vectors. We have viral vectors and we have synthetic vectors. The most commonly used is the adeno-associated virus. Why? Because of its high expression, long duration, low immunogenicity, and low heterogeneity. Let me explain with the help of an example. So here basically I have a video in which a gene is put into the vector. This gene vector complex is being inserted into the retina. It divides into a single-strand nucleus, a double-strand nucleus, and finally it gets integrated into the host organism. Now, we cannot go and give this gene therapy to anything and everything. There are certain prerequisites. The genetics of the disease needs to be understood. The treatment should be efficient and non-toxic. And there should be a control of the gene expression. Sir, aren't there any issues associated with gene therapy? Yes, it is basically short-lived in nature. It can lead to multi-gene disorders. It can lead to immune responses and insertion mutagenesis. Then, why are we taking the eye? Because it is immunologically privileged. It has a defined volume. It has a closed compartment. And the effect of therapy can be monitored very, very easily. So, all these diseases can be treated with gene therapy, particularly retinitis pigmentosa and Leber's congenital amaurosis. And the scope in ophthalmology is way beyond retinal disease, corneal disease, and various other diseases. To all the students who are sleeping in my class, if there is one point that you should take home from my presentation, it is that the first internationally approved drug for gene therapy is Luxturna, that is vortigene neparvovec racil, in which an RPE65 gene is being inserted into an RPE65 associated retinal dystrophy. And we have various things. In case of wet ARMD, we have SFLT01 protein which has anti-VEGF properties, and in case of dry ARMD, we have the CD59 molecule which acts against the dry ARMD. Corneal graft rejection can be prevented by putting angiostatin and endostatin, which prevents corneal neovascularization. Also, gene therapy has promising roles in case of glaucoma, and the last but not the least is the color blindness, in which the L-opsin deficiency can be treated with the help of gene therapy. So, guys, what do you think are the future trends? Advances in the prenatal diagnosis, advances in the prenatal treatment, advances in the genetic counseling, and can we actually have genetically engineered anti-aging eyes? Thank you.
One thing you can rest assured, nobody is going to sleep in your class.
Thank you, sir.
Secondly, I think you can reduce your histrionics and body language a little. People should concentrate on the content rather than your body language. I think that's important. So it's okay. I mean, you did a good job in your enthusiasm, probably.
Yes.
You overacted.
But I have one thing to add, because
yes,
something which is not very understood, you made people, you forced them to understand. Okay. Okay. Thank you.
Thank you, ma'am.
The next person is, and Ashish is the mentor.
Good morning, students. Hope you are enjoying the session here at AIOC. Since we're in Kerala, it's working here. It's working here. Can I just
Judge
restart?
in the next session. Judge in the next session. The last speaker.
Wait, I'll just change it. Good morning, students. Hope you are enjoying the sessions here at AIOC. Now, since we are in Kerala, let's talk about Kathakali, where eyes are the key for mastering it. And the beauty is binocular vision and binocular function. Similarly, when a patient with bilateral cataract comes to you, we need to preserve the binocular vision. Hence, today I, Dr. Ashmita Go, will be teaching you about the second eye cataract surgery. Let's see what are we going to learn in it. Why it's important, why is the surgery concerning, what is bilateral sequential eye surgery, and about a fun fact. It's important because it prevents anisometropia, amblyopia, better BSV, and increases visual field. A study by E.M. Talbot have shown that after the second eye surgery, there is an increase in simultaneous perception, fusion, stereopsis, acuity, contrast sensitivity, horizontal and vertical field of vision. Now, why is the surgery concerning? When a surgeon conducts any mistake in the first eye, he needs to rectify in the other eye. Why? To provide the best uncorrected vision to the patient. Now, if a patient has IFIS in first eye, he needs to maintain the mydriasis in the second eye and prevent the iris from prolapsing by these intraoperative measures. Students, take a note of it. Okay? Now, if there is a PCR, these intraoperative measures should be followed. If there is subluxation of lens, keep the CTR in hand. If there is a PPC, do hydrodelineation and remember to make a 4.5 to 5.5 millimeter rhexis. Now, if you keep multifocal, toric or tinted IOL in one eye, place a similar kind of IOL in the other eye. Okay? Now, what is bilateral sequential cataract surgery? It was popularized by Dr. Steve Ashdorf in 2008. It means that both the eye cataract surgery is done sequentially and it's two types, okay? Immediate and delayed. Now, when is immediate done? In patients having anesthesia complications and GA. In delayed, it's done most commonly in patients having within 4 to 7 days, and in patients having corneal pathologies, inaccurate biometries, lenticular abnormalities, high IOPs, and patients having cost constraints. The guidelines that's followed, that first this left eye OT will be done, followed by the right eye. Means you will see that the left eye dressing and draping is done, followed by the OT, and then he goes to the right eye. But before he conducts the right eye surgery, he needs to remember the surgeon has to change the gloves, the dressing should be done of the right eye, BSS, OVD and instrument tray has to be taken separately for the right eye. Okay, let's move forward. The advantage, most important, is quick rehabilitation and time and resource saving. And disadvantage is bilateral endophthalmitis, though the incidence have reduced. Now, by a study by Jonathan Malcolm have showed that the patients nowadays, if choice is given, prefer immediate sequential bilateral cataract surgery. And another, by very own J.S. Bhalla, a study is shown that in age of COVID-19, it has helped to decrease the surgical schedule and follow-up visits. And also, there is a significant benefit in reducing the infection exposure risk. Now, the pain perceived by the patient during the second eye surgery is much more, which might be due to the fact that the anxiety level during the second eye surgery is much less during the second eye surgery. Okay? Now, what's second eye syndrome? When a patient comes for the first eye cataract, it's a very new experience from him. But after the second eye, if he says that, I don't remember any of this from the last time, it's hilarious, right? What's that? That is second eye syndrome. Hence, I would like to conclude my class that if a patient to you comes with a bilateral cataract, please make them aware of immediate sequential bilateral cataract surgery. And you students should remember the conditions where it's contraindicated. Thank you.
Thank you, Asmita. I have got one comment for you and one question. Yes, the comment is that another place where you would do a bilateral, like simultaneous surgery, cataract surgery, would be with any patient having abnormalities of the spine and all, where you have to give special positioning to the patient with the microscope, but also keeping in mind the comfort level of the patient, because the patient should not get overtired, etc. So all these things would guide. And the question I have to you is that suppose by chance, when you planned a bilateral simultaneous surgery, if you have a problem in the first eye, would you go ahead with the second eye?
No, ma'am, then the concept of delayed simultaneous, like sequential bilateral cataract surgery has come. I would not do.
I think your speed of talking has to be slightly less, 10% less, because some of the words we could not actually make. The diction is very important.
Okay, sir.
The content was very good, but if you are not able to tell, the pronunciations and dictions are not optimum, then it can have a negative effect on your students. So I think that is something you should work on.
Thank you, sir.
No, I know the time is short, and you did a good job of kind of showing whatever
ma'am,
can
like
be done in a very
we
high
had to
speed
like
fashion.
finish it by 4 minutes.
That's all expected, but otherwise good presentation. Thank you.
And it was put forward as if like second surgery is a rectification for the person. So it is not like you gave it, points were there, but it came across as that.
Ma'am, since that topic, like I had to make it why it's important. Thank you.
So I think three of you all can sit here for. And yeah. So I think since the topics have already been given, so probably the content won't matter as much as presentation style, and I think ease of understanding and conceptual clarity. I think those should be the three if we all decide. So as a teacher, you check in the preview, not on stage. That's one. So all you're checking. If you're not ready, we'll call the next one. Right? Okay. The next one come in. You please check your slides there. Come back in. Are you done?
Yes.
Yes. Please start.
Good morning, class. So I would like to begin the class with a case. We have a 34-year-old female with these findings, and a diagnosis of primary open-angle glaucoma is made. What would your treatment of choice be? Okay, hold on to that answer. Now, what if I say the same female was pregnant with a gestational period of 6 weeks? Would your treatment of choice still be the same? So let's see if it can be the same. This brings us to the class today, glaucoma in pregnancy. I will be covering these topics. So aqueous humor dynamics includes aqueous production and aqueous outflow. Aqueous production occurs in the pars plicata of the ciliary body and involves three processes: ultrafiltration across the capillaries, active secretion across the non-pigment epithelium with the help of carbonic anhydrase, sodium potassium ATPase, and passive secretion of the water molecules across, forming the aqueous humor. Now the aqueous humor that is formed goes through the posterior chamber to the anterior chamber via the pupil and can follow two pathways, that is the conventional pathway and the uveoscleral pathway. So what exactly happens in pregnancy? So actually we have a reduction in IOP, and this is because of the interplay of these hormones at the level of production and also at the level of outflow. So at the level of production, pregnancy being a state of metabolic acidosis, there is inherent inhibition of the enzyme carbonic anhydrase, which reduces the production. At the level of outflow, pregnancy being a state of the reduced peripheral vascular resistance, it acts at the level of episcleral venous pressure too, reducing intraocular pressure. Apart from this, we also have the enzyme relaxin, the pregnancy hormone, which causes extracellular matrix remodeling at the level of the Schlemm's canal and the trabecular meshwork, which increases the outflow, thus reducing the intraocular pressure. So despite the normal physiological reduction in the intraocular pressure, if we have a raised intraocular pressure, what do? We reduce the IOP and also ensure the infant safety. So these are the treatment modalities that are available. So FDA has classified the drugs based on the safety profile in the pregnancy as category A to X, X being lethal. The safest drug is brimonidine, and the remaining anti-glaucoma medication belong to class C. So in the first 2 trimesters, we prescribed brimonidine and we switched to brinzolamide in the 3rd trimester. Punctal occlusion is advised to reduce the systemic absorption. Laser treatment is preferred in all the trimesters being safe. And these are the treatment modalities in laser that we have. Surgical treatment, if the disease is progressive and IOP is not controlled, we have to go ahead with the surgery, where we have to ensure different complications at various levels, right from the anesthesia, where there is exacerbation of the hypotension, hypercapnia, which is physiologically present, along with intraop, increased bleeding, surgical positioning, which exacerbates the hypotension, and also pre-op and post-op medications, which are teratogenic. So the timing of surgery is in second trimester. MIGS is the most commonly preferred drug, so commonly preferred surgical modality. So summarizing it, we have two classes of pregnant women that can walk into us. One which is already diagnosed, which requires preconceptional counseling and planning to reduce the dependency on the medication, and a newly diagnosed pregnant woman, wherein first 2 trimester we give brimonidine, third trimester we give brinzolamide, laser treatment is given throughout the pregnancy, and surgical treatment is preferred in the second trimester. So I hope the question and the answer to the question is cleared by the end of this class. Thank you.
Thank you, Dr. Rachna. Just one clarity. What was the topic given to you?
Glaucoma in pregnancy.
Yeah, so I think for everybody, just announce this was what was given to me, because it wasn't clear to us even till the end that what was the topic, right? Okay. Ma'am?
So that was a nice presentation.
Thank you, ma'am.
So, is there any preference to medication and laser the laser treatment? When would you
prefer
give the, you have said laser would be preferable throughout pregnancy.
So ma'am, if a pregnant woman comes, like in already diagnosed pregnant woman comes to us, then we can give it preconceptionally so that the dependency on the medication will reduce. So we can, instead of switching the medications and adding on to medications, we can switch to the laser treatment prior to the pregnancy planning and then continue with the medication.
Will you be following up any other parameters which would guide you, whether you can continue the medication or whether you would switch to some other mode of management?
Visual fields and OCT and the intraocular pressure routine monitoring every trimester based on the IOP measures will be preferable, ma'am. Sorry, sir? In glaucoma, usually it's open angle glaucoma. Okay. Angle closure glaucoma can be because of most commonly open angle glaucoma, but there is a slight incidence of angle closure glaucoma as well.
Would you like to qualify?
Sorry?
Like Dr. Saab said, they'll be less than 30 years old. Would you call it POAG, a technical error?
Would you, sorry ma'am?
What would be the definition of POAG? Sorry, you have a teacher
Oh, less
on the
than
other side. So.
Less than 30.
He said, no?
Okay.
A pregnant woman would be less than 30, early 30s at the most.
Yes, ma'am.
So technically?
Technically, it's not.
POAG is?
Less.
More than 40.
More than 40.
So what would she have?
Just the
JOAG, right?
gestation of man.
Right, okay. Ria, you're next. Come. Please announce your topic. Yeah, there are two of them. Timer set kariye, please. 4 minutes.
Can you set it here?
You set the timer, please.
Everyone. So when things get blurry, surgically readjust your focus. Yes, ma'am, come. Good morning, everyone. When things get blurry, readjust your focus. Why not surgically, right? Look at me. I'm a high myope with a -11 dioptosphere. I don't need these glasses, but my minimum corneal thickness is less than 500 micron. Can you suggest me any cases, any surgery for me? Come on, it's simple, right? Lens-based refractive procedure. And that, my dear friends, is my topic today. In lens-based refractive procedure, we have phakic IOL, refractive lens exchange, and bioptics. Phakic intraocular lens, it's a supplementary lens that is inserted to the anterior or posterior chamber of the eye to correct the refractive error. They are available in 3 forms, but due to unacceptable complication, only posterior chamber phakic IOL is used these days. The posterior chamber phakic IOL is inserted to the sulcus, giving an excellent cosmesis and protection to the endothelium. We do not touch the crystalline lens, hence the accommodation is preserved here. We can advise the phakic IOL in cases where LASIK is contraindicated, but he should be at least 21 years with no refractive or no other ocular pathologies and a stable refraction. How to do the workup? A detailed history and a thorough ocular examination, including the gonioscopy, has to be done. In this Pentacam, we get AC depth, which should be at least 2.8 millimeters, and a specular microscopy will give you the endothelial cell density. Determining the size of the phakic IOL is also of paramount importance. Now, this is a video of a toric phakic IOL which is being implanted here. A markerless system is used here and the incision is taken along the steeper axis. Once the AC is formed with viscoelastic, the IOL which is loaded into the cartridge is being injected. If you look carefully, you can see some central holes present in this IOL, which eliminates the need of a PI. Once the edges are tucked in, the visco is aspirated, the surgery is over. Simple, right? Post-operatively, what you'll do? You have to check the IOP and the vault. It should neither be a high vault nor a low vault. Now, what if the patient that comes to you already has a shallow AC or has presbyopia or a lenticular opacity? You can advise him refractive lens exchange. It is a removal of crystalline lens and replacing it with another IOL. Yes, the accommodation will be lost. So what will you do? You don't have to be worried because we have all these EDOF lenses, bifocals, trifocals, and based on the patient's requirements, expectation, ocular parameters, we can advise the following. Now, a last sentence about bioptics. It's just a combination of a keratorefractive procedure with an lens-based refractive procedure. So whatever the surgery is, my dear friends, everything has got its pros and cons. It is us surgeon, based on the patient's requirements, expectation, ocular pathology, we have to customize each cases. Thank you so much. Yes, sir.
If the patient comes with some posterior segment pathology and there is a harsh shoot there,
yes, sir.
ma'am, what should we do?
So first we have to treat the posterior segment pathology because this itself can lead to retinal detachment. So first we have to refer it to the retina specialist. They'll do if it can be replaced by laser, and then we can do the laser. And if there is a retinal detachment, then we'll go ahead with the surgery. If a laser is done, then after 1 or 2 weeks, we'll call up the patient. If we think it's stable, then we can go ahead with the surgery, sir.
I would like to know that
We will not do so.
what would be the difference between ACD and AQD?
AC depth. In AC depth, we don't consider the thickness of the cornea from the endothelial surface to the depth we are measuring,
That's
sir.
AQD. That's not ACD.
Oh, that's AQD. Okay, thanks.
You said the ACD cutoff for you would be 2.8. Is
Yes.
that right? Or the AQD should be 2.8.
It should be the AQD.
It should be the AQD.
Yes.
Right? And what's your cutoff for the endothelial cell count and the hexagonal cell percentage for a phakic IOL?
It should be 2000. Some say it is 2200, but then 2000 is also we can consider.
And what's the most important thing you should check post-operatively, and how much should be the measurement?
It's the wall, sir. So we measure the corneal thickness, and an ideal shape wall should be at least half corneal thickness to 1.5 corneal thickness. So if it is if it's an oversized phakic IOL which we have selected, then it will be high wall. So it pushes everything front, then the AC, the peripheral AC will be shallow, and it can cause to glaucoma, sir. And
I'm asking how much should the vault be for you to know that it's a perfect fit and it will not rotate and will not cause anything in the future?
It's 250 to 750. We compare it with the corneal thickness, half corneal thickness to 1.5 corneal thickness of the patient.
What's the corneal thickness got to do with it? How much should be the measurement? You're right. You said 250. 250 is actually too low, but yeah, 250. It should be around 500.
500 is a norm, yes.
Who was your mentor?
My mentor was Dr. Deepti Joshi.
Good job.
Thank you, sir. Thank you. Nice presentation.
Shall I start? Okay.
So today I feel very privileged to stand amongst this august gathering and my learned judges. Today I shall be discussing about congenital cranial dysinnovation disorders. Squint has always been a matter of intrigue among ophthalmologists since time immemorial. There was an entity which had sporadic, congenital, non-progressive element to it. People thought, what could that be? They thought maybe that's primarily a pathology of the muscle, and they termed it congenital fibrosis syndrome. This is a 9-gaze CP of a patient I'm sharing with you, where we can see in primary gaze there is a left exodeviation, and on attempted dextroversion in this patient, we can see that there is an upshoot. Well, such patients were there, but people could not make a clear understanding of what was the underlying pathology. Later, scientists thought, as I told you, it was originally termed as a primary pathology of the muscle and called as a congenital fibrosis syndrome because the pathological process was thought to be a fibrosis of the muscle itself. Later, doing the autopsy of such patients and doing the imaging of such patients, as you can see in this case, the abducens nerve can be seen on the left side, but you cannot appreciate it on the right side. So, an absence of the abducens nerve in a case of squint, well, clinicians again started to think, what was there which they were missing? They again sat together and realized the pathological process which was earlier thought to be primarily in eye muscles was actually a primary neuropathic and a secondary myopathic process. And thus came the birth of congenital cranial dysinnovation disorders. In 2002, there sat a congress which decided that from now on, all these disorders with a primary neuropathic and a secondary myopathic process would be termed and clubbed under congenital cranial dysinnovation disorders. This is a classification of the same. Because of paucity of time, I shall be running through it. There can be primarily vertical disorders like congenital fibrosis of extraocular muscles or ptosis, congenital ptosis, Duane's retraction syndrome, Okihiro syndrome, congenital facial palsy, and Mobius syndrome. A schematic diagram. In part B, you can realize the oculomotor nerve is present proximally but not distally. In part C, which is the case of DRS, you can see that the LR is not supplied by the 6th cranial nerve and has a misinnervation from the 3rd cranial nerve. They can occur at the level of microtubules, at the level of gene transcription or receptor signaling, as has been seen in CFUM and DRS. A DRS patient can have a problem during the adduction, which can cause a narrowing of the palpebral aperture, and during abduction, it can cause widening of the palpebral aperture. They can be divided into type 1, 2, and 3. And the management primarily involves aligning the eyes in primary position and reducing the upshoot and downshoot. A Y-splitting procedure was devised by Jampolsky in 1980 to reduce such cases where there can be a sudden upshoot, because a wide split would give a broad base for the innovation of for the insertion of the muscle. If they are associated with radial ray defects, as you can see here, or you can remember your pharmacology classes where there was phocomelia during thalidomide toxicity, they can be called as Okihiro syndrome. A CFUM patient generally presents with ptotic eyelids, infraducted globes, difficulty in supraduction, and a chin up position. A congenital ptosis patient, and a Mobius syndrome where there is a facial palsy along with the limited abduction of the affected eye. So my dear friends, I am glad that you could give me your patient time and listening. I would feel very humbled and grateful if you could understand the basic pathology which led to the development of CCDDs, that it is primarily a neuropathic and secondarily a myopathic process, which was done by years of research, autopsy examination, and imaging of these patients. Thank you and namaskaram.
Thank you. So, why does a co-contraction, what do you mean by co-contraction in some of these cases?
Ma'am, if I take a case of Duane's retraction syndrome, when there is a limited abduction or there is a congenital absence of a 6th cranial nerve, there is a misinnervation by the inferior division of the 3rd cranial nerve. Now, that 3rd cranial nerve, when the patient tries to do an adduction in that eye, there is a firing of the medial rectus, but the medial rectus simultaneously also fires the lateral rectus. Because of this simultaneous firing, both the nerves contract and try to pull the globe, and this leads to a reduction in the palpebral aperture during the adduction.
Just like to correct you somewhere, it's not Mobius, it's actually a Mebius syndrome. That's how it's pronounced.
Thank you so much, sir. Thank you so much.
Mebius syndrome.
Thank you so much.
And the other thing is, say a patient has come to you with a congenital fibrosis syndrome and severe ptosis and a huge chin-up head posture and wants to get rid of that chin-up head posture. What treatment would you offer to that patient?
So we would like to give a primary ptosis correction surgery first, so that the child
Ptosis correction surgery.
sling surgery would be good in such patients, sir.
What would be the material that you would like to use for the sling?
A frontalis sling can be used, or artificial materials can also be used.
Okay. And how much would you correct?
Sir, supramaximal correction. How much would you correct? We would like to do a supramaximal correction in such cases.
In congenital fibrosis syndrome, there would be no Bell's phenomenon.
We are not going to correct the muscle, but we will try.
Whatever you do, if you do supramaximal without any Bell's phenomenon, there will be severe corneal xerosis.
Yes, sir.
So you just clear the visual axis and leave it there.
Right, sir.
Would you touch the recti if a congenital fibrosis syndrome also comes with a squint?
Sir, if there is difficulty in abduction, as has been seen in certain cases, we can even do a correction of the recession. We can do a MR recession also in such cases.
You will not resect any muscle?
So resection would be a double whammy in such cases, because that can even lead to further tightening of the globe and difficulty later on.
Good.
Thank you so much. Thank you.
Morning everyone, I am Dr. Diksha and I have been given a very dry topic, corneal cross-linking. But I'll try to add some spice to it. So let's see how we begin. So this is my outline. So to begin with, what is cross-linking? Of course, creation of bonds. Which bonds? The strongest bonds that we know from chemistry are of course the covalent and the ionic bonds, and hence these bonds. Between two polymers, and hence we connect the two polymers and we create a new material that has altered physiochemical properties. So this is a chemistry. If all of you are really interested, I can begin this. But those who hated chemistry in their school are free to take a short Instagram break, right? So this is the molecule of riboflavin, and this has something called delocalized electrons. Now, can I have the cordless, please? These delocalized electrons can be photoactivated by UVA light to an excited triplet state of riboflavin, and this triplet state then interacts with the excited riboflavin then interacts with the substrate in aerobic and anaerobic reaction to bring about the product. And this process has been used in polymer chemistry and has been used to manufacture various prosthetics. So that is okay, it makes sense, but why would someone think of cross-linking cornea? So let's see the anatomy of cornea. And a cornea consists of regularly arranged lamellae of collagen, which provide biomechanical strength to a cornea. And there is a disease where this regular arrangement is altered. The disease is called keratoconus, in which there is thinning without collagenolisis. So these bonds are broken and the cornea loses its biomechanical strength, and there is progression of keratoconus. And hence, obviously, cross-linking will help. And this idea first arose in the city of Dresden in Germany in 1997, you cannot see it because of the timer, by Professor Eberhard Sperl, who thought of cross-linking the corneal buttons of a pig. He used various mechanisms, and a significant improvement in stress-strain index was seen. You can see here the stiffer cross-linked cornea. And 10 years later, human studies were done with something called Dresden protocol, which I'll come to later, and a significant reduction in progression of keratoconus was seen. More studies, and CXL achieved FDA approval in 2016. So brief slide about the technique. This is the cornea. First, the epithelium is removed. We inject riboflavin. The photosensitizer is now in the place. What next do we need? Of course, light, UVA light, which will create the cross links, and the process ends with placement of PCL. Now, this is the photochemical reaction which is governed by this law. This law of Bunsen-Roscoe law of photochemical reciprocity, which says that if your total energy is constant, you can have the same photochemical reaction irrespective of the irradiance and the time. And the total energy set by the Dresden study was 5.4 joules per centimeter square. Now you can achieve this 5.4 by different mechanisms, 3 by 30 or 45 by 2, but not more than 45, because Wernley has reported that if irradiance is more than 45, the efficacy markedly decreases. Now the first one, where 3 milliwatt for 30 minutes, was the original Dresden protocol, the conventional CXL. It had excellent efficacy, but longer duration was the limitation. So we have this something called accelerated CXL, and similar results have been reported, and maximum efficacy is with 9 into 10 and 18 into 5. This is the most commonly used protocols of accelerated protocols. So these are the complications which I would skip because of paucity of time. We'll discuss this in the next class. And I would give a home task. First is to revise, and next is to read about the prerequisite for CXL, especially a pachymetric cutoff, which is very specific and there's a reason behind it. So please read about it. We'll discuss that in the next class along with other topics. Thank you. 365 nanometers, sir. Actually, many wavelengths were studied. Maximum efficacy was with the sunlight in the original study. But again, that was not practical. So next was this 365 nanometer. Oh, I cannot show it here. So that is a question for next class. Definitely, if, okay, I can tell that if the irradiance is more and if the cornea is thinner, the UV light can penetrate deeper, cause iritis, lens damage, endothelial damage. So the cutoff is 0.018 milliwatt minute per second. So if the cornea is thinner, you can have endothelial damage. And hence that is a prerequisite for CXL. Instill, sir, I showed the video.
Yes.
No, it penetrates.
You said then we inject.
Oh, sorry, that was my mistake. That was my mistake.
Okay, just one technical thing for the judges to note. This was supposed to be a PG program. So Prafulla, I had no idea whether a senior resident would be eligible because it is for junior residents who have not passed. It says that, postgraduates, right? It is. So we'll have to keep that in mind. Please make a note, judges, that she's not a postgraduate, she's a senior resident already. Both. Yeah, that's why I put this up, that Delhi has to take note of the fact that we are making a note that these were senior residents, they've passed, they're ophthalmologists already. Right, anyway,
But there would be something, sorry ma'am, there would be something that I would like to speak which would probably cheer you up before you climb down the days. This was a proper class feeling. I loved it.
Thank you, sir. Thank you so much.
Vaishya, is she there? All right. So on to you, Dr. Bilal.
So good morning everyone. My name is Dr. Bilal Pathan. I will be presenting my seminar on lower lid eye reconstruction surgeries. Anatomy. Eyelid is a bilaminar complex structure, protects the globe, maintains the integrity of the tear film, divided into three parts. Anterior layer skin, muscle, middle septum fat, and posterior conjunctiva and tarsus. Anatomy mainly consists of septum, capsulopalpebral ligament, and septal spaces. Skin, thinnest measuring up to 0.3 mm, and there is no scarring. Orbicularis oculi muscle divided into preseptal, pretarsal, and orbital part. Orbital septum separates the eyelid from deep structures, and it acts as a barrier, prevents the infection, hemorrhage, and inflammation. Tarsal plates, these are connective tissue which supports the eyelid. Now we start with wound construction. It's like restore and replace, like with like, and the construction depends on anatomical integrity, physiological functioning, and osmosis and blending. So the main thing is while constructing, at least one must have its own blood supply. Technique would depend on the size, location, and configuration, depth of defect. Superficial defect, only anterior lamella needs to be repaired, and full thickness defect, it needs the construction of both layers. Principle, three components are must: outer layer of skin, inner layer of mucosa, and the semi-rigid skeleton. Periocular zones 1, 2, 3, 4, and 5. We are mainly dealing with zone 2, 3, and 4. Zone 2, lower lid. Zone 3, medial canthus, and zone 4, lateral canthus. Stepwise approach. First, we classify the defects: anatomical, congenital, coloboma, facial defect, epicanthal fold, and anatomical defects which are acquired, trauma, burn, and carcinomas. Functional defect: congenital, ectropia, and telecanthus, and acquired, ectropia, entropion, and telecanthus. Biomechanical defects: aging, exophthalmos, injuries, medical diseases, palsies, etc. Timing of the repairing: if cornea is exposed in a congenital defect, repair within first week; cornea not exposed, delay for a year. Traumatic repairs: primary within 24 hours, delayed primary repair 3 to 4 days, secondary for 6 months. Small defects: direct closure, primary pentagonal dog ear, Direct closure with lateral cantholysis, in which we directly detach the lower limb and angles incision superiorly. Moderate size defects, tensile flap is used. Advantages: reconstruction of anterior lamellar defects. Disadvantage: no lash restoration. Second, huge flap. In this, we do a vertical upper lid and lower lid sharing. And advantages: reconstruction of large defects, composite flap. Mustarde flap, it is a good flap for very large defect, and it's a single stage procedure. Calhoun's composite eyelid graft, we take a graft from anywhere and just we stick it in the lower lid. Large defects, mustarde, cheek skin is used. Fricase flap, we use the skin from the temporal side. Median forehead flap, nasolabial, we use the flap from the forehead. Split finger flap, reconstruction of medial canthus for zone 3 and lateral canthus region for zone 4. Blepharoplasty, in which we do the tightening of the lower skin and remove the excess fat. Transconjunctival blepharoplasty, in which the fat pockets are removed from the inside of the eyelid. Most important thing is the pre-aponeurotic post-orbicular space and orbicular muscle should be preserved. Carcinoma surgeries divided into frozen and Mohs surgery. The reconstruction depends on the type and defect or the size of the eyelid removed, and then they are reconstructed with the flaps which I have mentioned. Direct closure complication, notching, wound dehiscence, tension. Graft complications, scar, graft. Eyelid sharing flap complication, malposition. Most common complication is chemosis, epiphora, ectropion, retraction, ptosis. Take home message: 30% of the lid can be closed primarily. Lateral canthotomy or cantholysis can also close the primary, can allow the primary closure of large defect. Skin only defect can frequently be reconstructed with contralateral eyelid skin. And tarsal for graft is used. Prevention of tension, proper anchoring, critical anchoring. Thank you.
So, when you take a free graft for the anterior and posterior lamella, what do you have to keep in mind?
First, the first thing is the size of the defect and the anatomical plane from where you are taking, and the second thing is the blood supply of the graft.
So, can you take a free graft for the skin, anterior lamella as well as the posterior lamella?
No, we can take only for anterior lamella because it's the easy and there are more vessels, but for posterior lamella it's very difficult for a free graft because there are no proper supply.
Which year are you in?
Second year.
The second year postgraduate.
Second year postgraduate.
Okay. So, I mean, this is just again another comment, and
Yes,
since
sir.
this podia, these platforms have been given to all of you, because the AIOS wants people to be groomed, you know, and one of the primordial things that you should understand, all of you should understand, if you want to become a reasonable orator in the future, is to have a stage presence. And the stage presence comes from the fact that you have to understand your audience. Herein, you are actually essentially addressing the class, your students. And as a teacher, you should have that body language which speaks of confidence. You had everything in the slides, tremendous content. But probably, you know, the authority, that gravity, the dearth in your voice should have been a little more pronounced than it was, is what I feel.
The class is for 40 minutes.
Yes.
You have to keep us attentive for 40 minutes.
You know, what I meant was, please understand and kindly take it in a constructive manner. There is a difference between explaining things and reading out what is written on the vision. There is a difference. That's what I hope the hint would make you understand what I'm trying to say.
Thank you.
Good luck.
Thanks.
Next is Dr.
Good morning, all of you. My topic is minimally invasive orbital surgery. 20 to 30 years back, we never could have imagined that today we will talk about minimally invasive orbital surgeries. Minimally access surgery has gained popularity in many fields of ophthalmology. The orbit is an anatomically complex region that is affected by heterogeneous pathologies. Therefore, we need a collective knowledge of and skills of neurosurgeons and ENT surgeons and ophthalmologists. The overriding principle in orbital surgery is to preserve vision, and to achieve this, we have to choose the most appropriate surgical approach to avoid manipulation of optic nerve and its vascular supply. Pathologies in lateral aspect of orbit is accessed via external approaches including lateral orbitotomy and frontotemporal craniotomy. Pathologies involving medial aspect of orbit is accessed via anterior medial microorbitotomy, and lesions close to orbital apex is accessed via endoscopic endonasal approach. This is the clockwise model showing the access to the orbit for various approaches from 12 to 12 o'clock. This is the surgical entry sites in orbit. Like A shows the classic stellar right lateral orbitotomy. B shows the eyelid crease lateral orbitotomy approach. We will discuss in short about medial orbitotomy approach, which includes transconjunctival, transpalpebral and transcaruncular approach. In transconjunctival approach, we will approach the axis, we will approach to orbit via 1 to 6 o'clock in the orbit, and this is suitable for the tumors located adjacent to globe surface and excellent for evacuation and drainage of mucoceles. In transcaruncular approach, dissection begins between caruncle and plica semilunaris. In transpalpebral approach, it offers a minimally invasive alternative to frontotemporal craniotomy. The main advantage of this approach is the avoidance of coronal skin flaps and good access to orbital roof. Indications includes inferior and medial lesions, Tenon's capsule pathology and cavernomas. Endoscopic endonasal approach is to facilitate dealing with orbital fractures and lesions behind the globe in the inferomedial orbit. These approaches are included in endoscopic endonasal approach. Its advantages are good cosmetic result, not very invasive and fast recovery, but disadvantages includes it requires familiarity with endoscopy. Lateral orbitotomy includes eyelid crease and lateral canthotomy. It is very less invasive than transcranial approach and offers the option of adding an osteotomy. This is the picture showing the lateral orbitotomy in which the orbit is accessed from 8 to 10 o'clock, and then eyelid crease and lateral canthotomy is done. In this approach, superior eyelid crease, it is useful for the management of pathologies of frontal sinus and posterior wall fractures. In precaruncular approach, it is indicated in cases involving cavernous carotid artery and medial aspect of cavernous sinus and optic nerves. A short note about minimally invasive surgery for intraconal orbital surgery. Tumors were classified on the basis of its relationship with optic nerve in 5 groups. These are the 5 groups in which they were classified. And endonasal approach was done in type 1 and type 2 lesions. Most common diagnosis was cavernous hemangioma. Conclusion: the minimally invasive operating technique leads to less pain, faster recovery, quicker return to work and better cosmetic results. Thank you.
The judges would like to. Any comment? Any comment to that about the presentation?
No, whatever Anurag has said previously, no. You may have more than 10-15 medical colleges. You have got the opportunity to make use of it. Don't get scared. When you are teaching us, you are the most informed person. Understand?
Okay, sir. Thank you.
So if I could just comment upon the slides. No, it's 10, 20, 30 usually. 10 slides, 20 points, and not more than 30 point size for your font size. Because there's no point in putting in lots and lots of sentences on a slide, because they could just go back home and read that, isn't it? You have to distill all that you want to say in points. This is this, and the rest has to be saying. So the one thing that is, learn to talk to your audience rather than read from your slide, because they can see what is written. So it's easy to make a presentation, believe me. But all the presentations that you see and you think are nice, believe me, those people have worked very hard, and I can tell you it takes me about 6 to 8 hours to make an 8-minute presentation, and I'm not joking. Because while making it, you'll think, acha, there was that guy, and then you search for them, and then you want follow-ups, and then you want something. It looks easy. The easiest thing to do is to copy and paste abstracts, copy and paste text, copy and paste pictures, but it defines a good teacher from an everyday teacher when you know what you have to say. You're saying all that you have presented on the slide, but you're not putting it on the slide at all, right? So that's one thing that I think more than content, we are looking at people who can get across the idea that you want to present here.
Every word out of that for all of you was a pearl, because that came right from a top-notch curator in the country. Honestly.
Yes.
Thank you. Next, and Deepika, I believe, will be ready. Tell us your topic, Samir, and who you are. Introduce yourself.
I'll be presenting on cataract surgery in 2030. I'm a third-year resident from Aravind Eye Hospital, Madurai. More than our past and present, we often think how the future is going to look like. A very good morning to one and all. Today we'll be trying to answer the question of how cataract surgery is going to turn out in our near future. So what can we expect in the upcoming decade? Let's see as we discuss the surgical technique, the intraocular lenses, the reversal of cataract, and the changing trends. With advances in the surgical technique and high patient expectations, cataract surgery is evolving rapidly to become a refractive surgery. This demands high surgical precision, and existing technologies such as the femtosecond laser assisted cataract surgery, the Optiwave refractive analyzer, and image-guided systems such as Varian and Callisto are going to play an important role in achieving the same. More recently, robotic surgical systems are being explored in the field of ophthalmology, which includes cataract surgery as well. Two such systems with high precision and stabilization are IRIS and PRECISE, which have shown excellent results in the preliminary studies. Coming to intraocular lenses, which have been constantly evolving ever since their invention, also promise an exciting future. To begin with, presbyopic IOLs attempt to overcome the disadvantages of a multifocal IOL as a group. In the current era of smartphones and smart TVs, it was inevitable to not have a smart IOL. They are made up of thermoplastic acrylic material which completely fills the capsular bag and retains the accommodative behavior. Accu focuses a small aperture in the center, which gives it a pinhole effect and increases the depth of focus. In accommodating IOLs, two types have shown encouraging results, the dual optic IOL and the fluid vision IOL. But the type that excites us the most is the perfect lens, where a low-grade femtosecond laser can be used for the post-operative adjustment of the IOL power and design, and this makes it especially exciting for a pediatric ophthalmologist as the IOL can be adjusted for ocular growth. Additionally, multifocality can also be added, and in case the patient doesn't tolerate it, it can be reversed, just like an eraser for a surgeon. Next up are the light adjustable IOLs, which are made up of photosensitive silicon macromer, allowing the use of UV light for post-operative adjustment. Telescopic IOL, this is a Lipschitz macular implant which has two mirrors in the center, magnifying the central rays by a factor of 2.5, making them especially useful for macular pathologies such as ARMD. IOLs are also being explored in the field of biosensing technologies and have been tried for the monitoring of intraocular glucose and IOP. Drug-eluting IOLs are the one where certain drugs are attached to the surface of the IOL and then slowly released inside the eye. Various antibiotics such as moxifloxacin has been tried for the prophylaxis of endophthalmitis, and various drugs with anti-proliferative properties have shown to prevent the formation of PCO. Coming to the part which has the potential of making all of us jobless, reversal of cataract. 3 compounds have shown encouraging results. The first one, N-acetylcarnosin, which has antioxidant properties and has shown improvement of visual acuity and reduction of glare. Sterols such as lanosterol and 25-hydroxycholesterol decrease the aggregation of crystallines in vitro, ex vivo, and animal models. Rosmarinic acid is a naturally occurring polyphenol with antioxidative properties which remodels the protein aggregates. And since we are in this beautiful land of coconuts, we found something very, very interesting. A study has shown that coconut water protects the lens from diabetic cataract in animal models. Such a simple thing can cause prevention of cataract. As we all know, cataract is the most common cause of preventable blindness, and as India transits from a low income to a middle income country, improved accessibility to eye care is expected, which will in turn improve the quality of life and decrease their dependency. A recent survey has shown that only 14% of ophthalmologists are exposed to phacoemulsification during their residency. This is concerning considering what the future demands. In conclusion, the future is very exciting and promising in the field of cataract surgery, something we should all look forward to. The future is not something we enter, the future is something we create. Thank you.
Interesting, yes. So once the cataract has occurred, is there some way you can form the lens without introducing an IOL?
So smart IOL, ma'am, is a type of, like, it is made up of thermoplastic acrylic material. So
What is LAL? Is it still in light adjustable?
Sorry, ma'am.
Light adjustable IOLs?
So light adjustable IOLs are made up of photosensitive silicon macromer, ma'am. So for the post-operatively, suppose we want to fine-tune the lens, suppose there was a refractive surprise or so what we can do, we can expose the lens to a localized UV light of wavelength 365 nanometer, and once we get the desired lens, we lock in the lens by exposing the entire IOL to the UV light.
Have they been found successful now?
It is being used, ma'am, in several practices, ma'am.
How long you have to drink coconut water? How much? Because it's so expensive. If I drink coconut water for 1 year now, I can get 2 eyes off it. So economically, surgery is better than coconut water.
When was the study published? You sure?
Which?
About the coconut water? Is it recent one?
Yes, ma'am. I think in the last 5 years it was published.
Any other comment? Thank you, Samir.
Thank you.
Can we have Deepika on?